morning. Good morning, everyone. Welcome to Pilsen, to AMR meeting, Rywlin meeting. Michael, and we will have the first introductory presentation about the AMR club by David Suster.
Good morning, everybody. How are you? I want to say thank you so much for this opportunity to be here today, for all the AMR members to get together again for another international symposium. So my name is David Schuster. I'm one of the members of the AMR. My father started this many years ago and has been working with various colleagues to keep this going for many, many years. So every few years there's an international symposium where we present a bunch of surgical pathology cases. And a lot of this is very dependent on the local organizers and the hosts. So, in this case, many thanks to Professor Michal, Michael, as well as everyone who helped organize, Christina, Marion, all of the members of the Bioptická Laboratory for putting this together on relatively short notice. So we have a wonderful course. I'm going to say a few things just about the AMR in general. I think I stole my father's presentation. He usually talks about this, but I think he's still asleep. So we'll go from here. So AMR stands for Arkadi and Rywlin. This is a picture of him. He was a pathologist. He was practicing in Mount Sinai Hospital in Miami, Florida, and he's one of the people who trained my father, and one of the reasons why my father is a pretty good surgical pathologist. So he was very well known for writing one of the first books on bone marrow pathology. So that's his book over here. And this was, a long time ago when there wasn't really that many books on pathology out there. And you can see here all of his credentials. So the AMR itself, here's a few, sort of data points on this. It's a non-for-profit international organization that's basically, devoted to promoting the practice of surgical pathology. And this was started by Saul Schuster in 1991, and over the years there's been over 100 members. Every now and then new members get added, and other members, they reach their careers and they retire. So hopefully we're able to keep this organization going for another generation coming up here. And essentially, a couple times a year, it conducts a slide exchange. So glass slides are mailed to all of the members of the group who are participating, as unknowns, and are usually with some information, and comments are submitted. And every now and then we have this meeting that we're all here for today. There's also, AMR has been highlighted in, various pathology-related magazines. This one is from The Pathologist. There's a nice article in there. And there's also a website that you can go to. You can see it's a little bit, it's not the most cutting-edge website, so kind of, very basic, but it's quite functional. So you can go there, you can see all the past seminars. A lot of times the cases are there. There's a lot of photographs from all the different seminars. In addition to that, the AMR has a section in Advances for Anatomic Pathology where members will publish specific cases from the conference itself will be published into anatomic, or Advances in Anatomic Pathology. So, that's a quick overview of the AMR. We've had quite a few different AMRs. These are some of the previous ones. We're on the 13th one now, but you can see some of them here. Multiple different cities. They always try to hold them in some international place rather than just having them in the United States, because it's just more fun to be able to travel and meet international colleagues than it is to just sit in the US. So, we've had the very first one was in Italy, but there's been ones in Mexico and Stockholm. Here's another, a little bit of the more recent ones, Split, Croatia, and the two most recent ones that were hosted were in Italy. We had one in Venice, which was a couple of years ago, which was quite nice, hosted by Dr. Silviato, which was a terrific course, and then we also had one in Porto in Portugal. So now here we are, for the 13th version of one of these, here in Pilsen, and I don't know if this worked or not. Oh, looks like it might have removed a couple of my notes here, but that's okay. Anyways, so that's a quick overview of the AMR. Usually there's also quite a few like social events. Some of our members, some current, some former, enjoying one of the dinners. So it's a nice opportunity because a lot of the faculty ends up becoming, in addition to colleagues, becomes friends and meets each other's families and everything. And then it's nice to be able to get together. So with that being said, welcome to this year's seminar. There will be a bunch of great cases and we'll go through them over the next 3 days. So thank you. And I think Professor Michal will have to say a couple of words as well about the laboratory. This is an amazing place that you're sitting in, so he's going to tell you a little bit about it.
Okay, thank you, David. I'd also like to say that I think it's been the second Rywlin Club meeting in the Czech Republic in 2005 in Šumava Mountains. So this is almost exactly 20 years after the second meeting. So I would like to say a few words about this lab. So we are Bioptická Laboratoř. This place is a private surgical pathology and molecular laboratory which provides histological, cytological, and molecular analysis for all types of hospitals and private practices. It was founded in 1993 here in Pilsen by my father and two of his former colleagues. And today it is one of the largest labs of its kind in Europe. We have roughly 300 employees, of which 43 are pathologists and 19 molecular biologists, and we operate on roughly 11,000 square meters. The lab also owns significant equity shares in two other large labs in Eastern Europe, in Slovakia. The lab is called Cytopathos, and also in Ukraine, where the lab is called CSD Healthcare. And collectively, we analyze over 450,000 surgical specimens a year. We also have a very close cooperation with the Department of Pathology and the Pilsner Medical Faculty. So what we do, we are basically a surgical pathology lab covering all aspects of the field. We perform histopathological examinations of all types of surgical specimens, of which we have close to 170,000 samples a year. We also have a large immunohistochemical lab with over 500 primary antibodies and perform 8,000 IHC stainings per year. In the last couple of years, we've been trying to implement AI in the analysis of the samples. We routinely perform all prostate biopsies with the help of AI. All liquid-based cytologies are done with AI. And we are trying to implement AI into the breast biopsy specimens analysis and thyroid and pulmonary cytologies as well. So our main clients, because we are a private lab, our main clients are basically private physicians, regional hospitals, but also some faculty hospitals in selected areas, and we perform consultation services for other pathologists, both from Czech Republic and from abroad. Our molecular lab especially, but also our immunohistochemical lab is performing a lot of analysis for pharma companies, which has become quite a significant source of income for this lab as well. Regarding the cytological examinations, the cytology department creates about 1/3 of our budget, and we mostly do gynecological cytology. We have almost 1 million samples from gynecological cytology a year, both conventional pap smears but also liquid-based cytologies. Another roughly 1/3 of our budget or our income is from molecular lab, where the primary aim is the molecular analysis of tumor samples for diagnostic, predictive, and prognostic purposes. We do both next-gen sequencing, methylation analysis, and also, of course, some traditional methods as FISH or RT-PCR and others. We also perform analysis of non-tumor tissues in some limited amount, for example, prenatal testing or microbiological testing, paternity testing, and so on. Overall, we do 85,000 molecular tests per year, of which almost 5,000 are NGS tests. So, although we are a private lab, our very significant part of our operation is research and educational activities, because actually research is the ultimate goal of this lab. It's actually the reason why it was founded by my father, because when he started in pathology, he realized he would like to do research, but after the fall of communism in the 90s, there was no money for it. So he figured that he will have to make his own money to fund his research and the research of his colleagues, and this actually has been working pretty well. Eventually, the main research focus are neoplastic processes and especially rare tumors. We basically do the traditional or conventional pathology studies, so it's basically applied research. We were studying morphological, immunohistochemical, and molecular markers of tumors in order to delineate clinically relevant novel entities or tumor subtypes, or provide novel ways how to more accurately diagnose the existing tumors. Almost all research is done jointly with the local department of pathology at the medical faculty. We together share a tumor registry, which currently stores over 160,000 cases of rare tumors. So this is a tumor depository where we deposit the interesting cases. So it's different storage than the routine archive where we have millions of samples. And this tumor registry has over 160,000 cases, of which almost half is digitalized, so very easily searchable. This is how the tumor registry looks like. If any one of you wants to go for a lab tour, there will be multiple occasions throughout the 3 days. Either ask me or my father, and we will be happy to take you around the lab. So this is how the cases are stored. Every case obviously has a number. And all the slides, all the blocks are stored in our cellars under the lab here. And this is a very old but very functional database program where you basically put in the keywords. Every case saved in the tumor registry has specific keywords, and by using a combination of the keywords, you can easily search all the cases. And as I mentioned, roughly half of them is digitalized. So although this software is very old, we have added the feature of using scan slides. So this is very, very useful for both looking for cases when you are doing research, but also for studying. If you want to study some rare tumors, it's a matter of seconds before you get the case you want to see. So overall, we do 50 to 70 research papers with impact factor per year, including papers in the most prestigious journals in the field of pathology. We are very proud of this. We've been cooperating with dozens of foreign institutions, including the most prestigious ones, and over the years, 6 pathologists from our lab have co-authored the WHO Blue Books, including Dr. Skálová, who is Alena Skálová. She is responsible for the cellular gland tumor chapter in WHO. She's the editor of this chapter. We also do every year we host dozens of Czech and foreign visitors, mainly pathologists, but also clinicians. We do also educational activities for clinicians. These people come here to learn or to train with us, especially pathologists. They come here to look at slides. And we organize meetings such as the one you are attending right now. Just in the last year, we've had a very nice urogenital pathology meeting in Michal in Czech Republic, and this February we hosted this event on bone and soft tissue pathology with all the main stars in the field. Also, every Tuesday we have these, we call it Tuesday multi-head seminars. Anybody can log in online, watch the slide seminar. It takes 1 hour. We show the most interesting cases from the last week, and also you can look at the recordings. You can just find it all on our website here. You can basically look back all the seminars we had. So some plans for the future. I'm getting to the end. So you entered, or you're sitting actually in this building right here. The lab basically occupies roughly half of this block of buildings. You're sitting in the largest building here, and in the future Actually, in the present, we bought these two houses. It's not, now it's one house on this picture because this is our plan. We want to basically tear down the houses because they are not very well suited for lab. And we wanted to create a new building here where in the first 2 floors there will be basically auditoriums, larger auditoriums than this, so that we can host larger events than this as well. So it's future, like upcoming 5 to 6 years, we hope. And as many of you have seen yesterday, because we traveled to this nature reserve, part of the profit of this lab is basically donated to nature preservation. We basically use the money to buy land, which is valuable from the biological perspective, and we buy it to preserve it. So we basically buy it and we pretty much leave it alone, just to nature. This was an idea brought in by a former member of AMR Club, Professor Andra, who was a big nature lover, who unfortunately passed away a couple of years ago. So many members and many visitors visited this place yesterday as part of the trip. It's close to the German border, over 25 hectares of nature. So thank you for your attention, and let's start with the scientific program. The moderators, the academic section is coming up, and the moderators are Dr. Vanya Nose and Dr. Skálová. Thank you.
Maybe we should start.
Yeah, in interest of time, I think we should get going.
It's very, very fast to start, but let me first welcome you everybody. That's the first session, Head Pathology, and we shall co-chair with Vanya and myself, and it's my pleasure to start with the first speaker, with Fred Petersson, and now podium is yours.
Thank you. Okay, in interest of time, I think we better get going. I have a number of slides, but I will flip through them fairly quickly. But the first one, normally I am but I live in Southeast Asia. So when I give talks in Asia, especially if there is a significant body of ethnic Chinese in the audience, I start with this slide to break the ice and to check whether they are educated in their own history. So, who is this fellow? Yeah, I don't expect anyone here to recognize if there's somebody else with a bonus prize. So this is actually Bodhidharma. He is, according to legend, the Indian Buddhist monk that transmitted Buddhism into China. Most of them failed this question, but it shows that I'm familiar with their history and culture. So this is Bodhidharma, and he was called by the Chinese the bearded barbarian from the West, and then I emphasize that designation has already been taken. Okay. Anyway, so stop with the case. So this is a very young Chinese guy who presented very early. I should. Like that. So in 2008, he presented with a tumor in the left lacrimal sac or maxillary sinus, and he has had multiple recurrences since then, and it's been called many things, but mainly in the ballpark of inverted papilloma with various degrees of dysplasia and eventually malignant transformation. 2017, it was made the first malignant diagnosis, and he was then subsequently treated with chemo-RT plus resection, but again, he has recurred numerous times. He's currently disease-free though, although quite disfigured because of quite mutilating surgery, but he's alive and well. So this is first, I will flip through a number of slides here. With a tumor. So this is the biopsy in 2011 from a blood point lesion in the left maxillary antron. You can see here, I'm not going to comment too much on it. You see here is a little bit of a well-demarcated inverted pattern of tumor. It's called Schneiderian papilloma, inverted papilloma with dysplasia, blah, blah, blah. Again, 2011, two more, again, the same thing. You can see that it's not on low power very far-fetched to sort of think in terms of inverted papilloma. You see here, well demarcated nests. Pathology is not good though. So again, I don't know what it was called. This is again 2011, left orbital resection. And this is 2013. Again, a recurrence, papillomatous inverted architecture. Quite hypercellular, but the cells are fairly monotonous. So I call again IP with severe dysplasia, 2017, and recurrence. Basically the same pattern, inverted, papillomatous, well demarcated, very cellular, though mitotic figures, if you look for it, not difficult to come across. Here there is an area, let me see now if this works. Here, you see it was perceived as possible transformation then to lymphoepithelial type of SCC or lymphoepithelial carcinoma. You can see here there's a little bit of irregular nest formation and a lot of lymphocytes and vessels involved. So it was called then inverted Schneiderian papilloma, dysplasia, malignant transformation, vascularization, so forth. Here then he received chemo-RT in addition, but he recurred again, 2019, left orbit. Same pattern, you see the hyalinized connective tissue here is secondary to the radiation. As I said, fairly monotonous, but very cellular. It was called SCC, and again 2020, resection again or recurrence. We call papillary SCC with a long comment. I'm not going to bother with that, but when the comment is long like that, probably the pathologist is a little bit in deep waters, you see that? So what is going on here? It is the same tumor throughout all these years, because we had sort of coming together and we went through all it, and this is actually the magic bullet. You can see here the immunohistochemistry, and you see here there is something positive in the nuclei, and this is after immunohistochemistry done on the 27th resection, which was called malignant. So this is after translocated non-keratinizing squamous cell carcinoma. It's a new kid on the block. And I'm sure puts it in a category together with the non-keratinizing SCCs in the sinonasal tract mainly. It was initially described as late as 2019, and subsequently several studies have documented this genetic alteration in squamous cell carcinomas of the sinonasal tract, but also middle ear, mastoid region, temporal bone, lacrimal sac, and nasolacrimal duct, and nasopharynx. So those were the main sites. Well, I'm not sure it's rare, because we've seen quite a number. I don't know, but we send them here for IHC, and I think we constitute not insignificant number of DEC after carcinomas in the registry, correct? Yes. Yeah. So slight female preponderance, wide age range, multiple sites, but propensity for sinonasal tract, as I said, middle ear, temporal bone, mastoid region. They are typically patients experience frequent local recurrences, but also lymph node and distant metastasis. They not infrequently present with very advanced stage at presentation, and so far 1/4 of the patients have died of disease. So what have they previously been reported as? Yeah, it's HPV-independent non-keratinizing SCC, Schneiderian papilloma, as in our case, dysplasia and carcinoma X. Transitional carcinoma is an old term that I think covers this thing, and also low-grade Schneiderian carcinoma, so if you worry about that a little later on. So this is what, in this paper, what in molecularly established cases of DEC after SCC, these were the initial diagnosis. Okay, a few words about low-grade papillary Schneiderian carcinoma. This is most likely DEC-AF2, and it has been shown in one study here by co-workers in 4 cases. They are characterized by not brutal cellular pleomorphism, frequent recurrences, kind of low grade in most cases. So I think that now it's fairly accepted that this alleged entity is part of the DEC-AF2 translocated spectrum of squamous cell carcinoma. Most characteristic histopathologic features are those of a tumor with complex broad exophytic papillary growth and endophytic lobules and cohesive nest. The neoplastic cells are basal sort of quote-unquote transitional type epithelium with absent or very limited keratinization. The tumor cell nuclei, as with all translocation-driven tumors, are fairly monotonous, often have a prominent inflammatory reaction, either neutrophils, even with small microabscesses and lymphoid cells can also be seen. There can be, in quite a number of cases, a catalytic discohesion that derives to sort of pseudopapillary formation. Yeah, so here are examples from the literature. You will see these complex confluent exophytic and endophytic growth, broad papillary structures, anastomosing lobules. Again, more of the same from the literature. Papillomatous, inverted to the right here. It's almost like a trabecular kind of arrangement. And you can get cohesion and coalescence of the nest, so you have a more sheet-like appearance. Generally a more pushing, broad-based infiltrative pattern, but they can also be frankly infiltrative. So again, basaloid to transitional type cells, limited or no keratinization. You can get peripheral palisading, which makes a diagnosis, differential diagnosis of basaloid SCC. Okay, more. So, frequently striking nuclear or cellular monotony around oval-shaped nuclei, not much in terms of pleomorphism, and inflammatory infiltrate, you can see here to the right. These are examples of tumor cells with more pronounced cellular atypia, larger nuclei, more prominent nucleoli, but they still show a monotonous appearance. Yeah, and again, I mentioned this about the neutrophilic infiltrate. Yeah. So you can get acantholytic changes here with formation of pseudopapillomatous structures like there, and also almost like a stellate reticulum type appearance, admixed with neutrophils. Usually the mitotic activity is fairly low, but there's a wide range. So there are cases with high mitotic activity. Necrosis is not so common. And I will show you now what, so there is a wider spectrum than it was initially described with sort of morphological outliers. And I've taken this from the literature, I'm just going to flip through. So you can get whorls, morules, clear cell change, you can get tumor cells lined by ciliated non-neoplastic cells, you can get microcysts and even overt glandular formation. I think the Washington group published a paper on adenosquamous carcinoma with DEC-AF2 translocation. So the morphological spectrum is wide, and there are also cases with more cellular atypia, pleomorphism, and also with typical mitotic figures. So that's important to bear in mind for the practicing pathologists. Immunohistochemistry, nothing exciting, positive for squamous markers, can be positive for CD99, as many things can be, and negative for the rest. And importantly, so far there has been no strong and unequivocal expression of P16, because the differential here is the sort of HPV-associated non-keratinase C. But you can get P16 expression, though, but not that block positivity usually associated, or should be associated. And the Ki67 index ranges from 5 to 65%, but the median is still quite low, about 10%. Yeah. AF2 immunohistochemistry, very useful tool. It's very sensitive, 100% reported, 100% sensitivity, and very high specificity. I put an asterisk there because there is this paper that I found with an unclassified neuroendocrine tumor with a CHD4 AF2 fusion. They didn't do immunohistochemistry, but I would expect this to be positive, so it's not 100% specific. So it's 30% nuclear immunoactivity, any intensity is considered positive. But you can do molecular as well. You can do RNA sequencing or break apart fish. This paper is interesting because it shows that there is as of now, there seems to be a very consistent breakpoint in exon 7 in the DEC gene, whereas the breakpoint in the AF2 gene is more variable for those who are molecular inclined. Of course, negative for HPV and EBV, and they are also negative for EGFR and KRAS mutations, which are typically seen in IPs, inverted papillomas, and also retained in the squamous cell carcinomas developing from inverted papillomas. Yeah, the differential diagnosis is broad, and I have to say here, of course, all round cell sarcomas may come into play. I not go through them because I don't master that area. But HPV-related SCC, of course, important. Basaloid SCC, it can be HPV positive or negative depending on the site. And of course, malignancy and dysplasia arising from an IP. Nasopharyngeal carcinoma or sinonasal lymphoepithelial carcinoma is another differential, SNAC. And on a small biopsy, you may also consider HPV-related multiphenotypic sinonasal as carcinoma, and SMART B1 and SMART A4 deficient carcinomas also come into the discussion. And other multinormal sarcoma as well. I'm not going through. There are you will get this in the handout. So I'm just gonna, when I went through the literature here, I'm just going to present some interesting cases. There is now a nut carcinoma with a very bland morphologic appearance in the sinonasal tract. You can see an invasive part, not very pleomorphic. And it has it's not the nut BRD3 fusion, but not NSD3 gene fusion. I don't know what NSD3 is, but it is a nut carcinoma. I don't know if they have a different prognosis compared to the conventional ones. And I also found this paper hot off the press. And I was going, if I was here, I was going to say I found this in a paper by a very young and upcoming pathologist by the name of Dr. Agami. So in this cohort of tumors with FGFR3 and TAC3 fusions, I'm soon done, there was one case there from the parotid which had a very DEC-AF2-like appearance, which I agree with. You see the dense neutrophilic aggregates, the cohesive nests. And also I mentioned this, there is this AF2 translocated neuroendocrine malignancy, which would then be positive on IHC. So the prognosis for these ones is not good. They are aggressive tumors, frequent recurrences. Maybe because of delayed diagnosis, but they do metastasize. There is no correlation so far with morphology, mitotic activity, Ki67 index, and here you can see that they actually do worse than the conventional and the HPV-associated ones. There are now also additional sites reported. This is from the larynx, this is from the thorax, and the take-home messages here are, this is a new kid on the block, proclivity for sinonasal tract with wider anatomic spectrum. I expect more sites to be reported when people become aware of it. Wide morphological spectrum, broad differential diagnosis, IHC for AF2 very valuable too, and despite most often bland morphology, aggressive behavior, and now also, as I said, in other sites. And this concludes my talk, and this is Xicomecoatl. This is the Aztec symbolic representation of sustenance, the concept of substance. And sustenance has to do with agriculture. You can see here the corn crops that this goddess, beautiful statue. Okay.
Brad, thank you very much. much, and I would like to congratulate a wonderful presentation. If you want to discuss comments, there is a microphone close to the wall. Please use the microphone for any comments. We have 15 minutes for presentation of one case. Fred was a little bit longer, but my next case is very short, so we still have some space to discuss this. I mean, very nice example of DEC-F translocated carcinoma. We have in our registry 5 cases, maybe more, and this is very typical. Recurrences, very blunt morphology, and finally this translocated carcinoma. Marian Schweiler.
I've got a question to Fred. How paranoid are you where you are signing out like Schneiderian papilloma-like tumor?
It's getting worse and worse.
Yeah.
Getting worse and worse. I'm now very nervous about making a diagnosis of inverted papilloma. I think it's part and parcel of the workup of this inverted, not very squamous differentiation, not very much squamous differentiation like microscopy. The moment I see a few mitosis, I will send. I just sent a case to here very recently, which I didn't see myself, but they sent me pictures. My team sent me pictures on, and I said, send for IHC, and it is super bland, but let's see if it's possible or not, I don't know. But I'm very paranoid.
This is probably what we are doing here. We are doing immunohistochemistry quite liberally for almost every case.
Because otherwise there will be some cases that you miss. You call it IP with some atypical features. No, you're probably dealing with the DEC-F2 SEC.
That's right, I very much agree, and we are lucky in this case that surrogate marker AFF is relatively reliable, not like the others. Ivan Damiano.
Is this an early change molecularly? Namely, did you try to see whether it was present in the original biopsy?
No, I didn't do, but no, this is, okay, I have to be a bit intellectually brutal here. This is the same tumor, the DEC-F2 translocation is a driver, and it is, I would guarantee you 100% that it was present in the first one. The question though, Ivan, is that whether those cases with more cellular atypical pleomorphism have acquired more mutations, it will be very interesting to correlate a more full genotype with morphology to see whether there is progression. I mean, you can get biological progression of a tumor, so I'm very interested in that. But I would guarantee you, Ivan, that the DEC-F2 translocation was present in the initial tumor manifestation.
Because, you showed that it is obviously becoming more and more malignant. So I'm wondering whether there was something else. And the original...
I'm not sure it became more, I mean, I have to be selective here. We have tons of tumor from this one.
It's more to the Bioptická people who are probably experienced with more cases. So is it a second change that occurs during the progression of the...
That's what I alluded to. This is not known. It was an interesting question.
I agree, but we have cases where this translocated change, this translocation has been seen in the first biopsy. And we have one case recurrent where the translocation was equal, as far as I remember, in the first and recurrent tumor. So I believe that it's a really early event. So if you agree, we'll move, and I will ask my co-chair, Vanya, to change.
So, besides, we are in a beautiful city, in a beautiful place, in a beautiful lab, and we have to thank the organizers for this wonderful, and Dr. Michal, Michael, Michal, and Saul, Suster, and so forth. But anyway, we have the pleasure to have the best, to my point of view, and to the world's point of view, the best salivary gland pathologist to present our case. She's from Bioptická, and Skálová is, besides, the best one, the most knowledgeable in salivary gland. She's our friend, so that's good. So, Alina.
Thank you, Vanya, for introducing me. I'm by far not feeling as the best salivary gland pathologist, not at all. But thank you for kind words to introduce me. I don't need this here. Okay, so as Marian Schweidler, the head doctor from Bioptická, always say, he says, it's very easy case. So my case number 2 is very easy. So you can see that the tumor has been located in sublingual gland. That's a mistake in your program. I introduced the tumor as a submandibular, but then I decided to use the other example of the same tumor. So this is the tumor of left sublingual salivary gland of a 52-year-old female patient. The tumor was well circumscribed, almost encapsulated, and on gross examination it was solid inconsistency, and on cross section, on the section focally hemorrhagic, size 15 by 12 by 9 millimeters. And well, this is a consult case. Diagnosis was given salivary gland adenoma, not otherwise specified, because of low-grade histomorphology and lack of apparent lymphovascular or perineural invasion, and it was sent for second opinion. The history of the patient was not very happy. I mean, one day after surgery, the patient had to be brought to emergency room for bleeding from a surgical wound sublingually. There was a huge hematoma on the floor of the mouth, and there was a revision needed, a revision of the wound that was performed using extraoral approach, and the patient was in delirious state because of increasing swelling in the floor of the mouth and still bleeding. So she had some difficulties because of the surgery, but finally, she recovered after this second intervention, and in the second re-excision from the tumor bed that was taken during the second surgery, that was done immediately the second day, there was no tumor residue in this resected tumor bed. Well, and we have a follow-up a little bit more than 2 years after primary surgery. There is no evidence of recurrent or progressive disease, and next control of the patient is scheduled to November this year. I will go fast through the sections, which I believe you had the opportunity to see. The tumor is well circumscribed, even encapsulated, as we can see here. The capsule is highly nice, quite thick, and there was not extremely obvious invasion of the surrounding tissue. And if you look at the slide at the tumor itself, it's quite regular, composed of sort of trabecular or solid growth patterns, and quite prominent feature, at least to my eyes, is the presence of multiple blood vessels with hyalinized walls and some nice palisading around, and maybe even pseudo rosette formation which is seen also here around the blood vessels and hyalinized stroma. So these are prominent features. On high magnification, still you can appreciate the cells are quite regular, with here and there a little bit enlarged nuclei, distinctive nucleoli, and if you really looked carefully, there are some, but not very visible, hardly visible ducts, tiny ducts in the tissue. Once again, if you look for the ducts, it's difficult on H&E, but we can see them. Once more, another example, palisading and quite regular cells with a little bit somehow resemblance to neuroendocrine tumor. So my question mark asks about your considerations, you can think about it, and I will present at least the immunohistochemical findings, which were not very abundant. This is cytokeratin, AE1, AE3, and you can see that what I was telling you about these. No, it does not work. Yeah, it works. What I was telling about presence of these tiny ducts, it's more visible when we use pine cytokeratins. Okay, so the predominant cells were positive for cytokeratins, but the positivity was much more enhanced in these ductal structures. And here you can appreciate the presence of the ductal, tiny ducts in a more selective cytokeratin staining with CK14. You can see that the predominant cell type is negative while ducts are positive, and there is some periductal positivity for P63, and that predominant cell type is negative. One more, CAM52, again very similar pattern of strong positivity in ductal structures and mild positivity in predominant. The same with CK7, with a strong positivity in these irregular tiny ductal structures. The predominant cell type is sort of abluminal cells of the tumor were negative for everything, which is very typical exception of CD56, which was completely positive, and androgen receptors. So these were the only really strong positive markers. And if I somehow summarize the immunohistochemical findings, it seems obvious that the tumor is biphasic somehow. The group of luminal cells has been shown to be strongly positive for cytokeratins, and some did also have some substem staining, but most of these markers were absolutely negative in predominant abluminal component, which was only stained for androgen receptors and CD56. Significantly, the other neuroendocrine markers, more specific, synaptophysin, chromogranin, and were negative. So all of these stainings were negative. Targeted next generation sequencing, unfortunately or fortunately, that's typical for this entity, did not reveal any translocation or oncogenic mutation. So, diagnosis is this one, palisading adenocarcinoma of sublingual gland. I don't know if you heard about it, it's an emerging entity. It's simply very new. This is the first description from Justin Bishop and collaborators. And this palisading adenocarcinoma has been described on 9 cases in this paper, that's the first one, as a tumor with predilection to sublingual gland. Maybe there are some cases on submandibular as well, but sublingual in women. And quite typical is this quite sort of neuroendocrine-like appearance with palisading along the septa. There are only two more papers published last year as case reports. Both these were published, were the cases of female patients in sublingual gland and female in submandibular gland. So here you have 2 distinctive case reports, and that's it. So we do not have really big experience with the palisading adenocarcinoma. This is how the tumor looks like in the paper published by Justin Bishop, and you can see that it's identical to our case. So if I review again, the tumor is biphasic with a tiny ducts seen here and there, but very predominant population of polygonal cells that are palisading and forming pseudoresecs around hyalinized stroma or vessels, and this resemblance of neuroendocrine tumors has been mentioned in all 3 papers that were published so far. Most cases are well circumscribed, but there are a minority of cases with limited infiltrative growth, so that was the reason why palisading adenocarcinoma has been given to this tumor. So if I conclude, and you see my presentation is pretty short, we have experience now with 3 cases of this very new emerging entity. All these cases were sent as a consult with a benign diagnosis in most of them, in 2 of them, one with adenocarcinoma not otherwise specified. And whether this palisading adenocarcinoma really will be considered as a new tumor in so long a list of salivary gland tumors already present, but it's a question which is now open for discussion. Nevertheless, it seems to me that also based on the experience with 3 cases which I have been consulted for, it has distinct clinical settings, female, sublingual, and this pattern which looks like neuroendocrine, but it's not endocrine, forming pseudoresecs and palisading. This is a repetitive feature. And that is interesting question that came to my mind. Dignity of this is quite questionable, yeah, because the tumor which you have seen was pretty nicely circumscribed and encircled by capsule, no invasion. So I looked in the literature. Most of the cases is without that were published in the literature, without invasion, and all of them, even those with limited invasion to the gland, have indolent behavior. But we know, we salivary gland pathologists, we know that even this kind of behavior means low-grade malignancy, like that's the history of mucoepidermoid carcinoma or acinic cell carcinoma. So probably the name palisading adenocarcinoma low-grade will be accepted with this, that most of the patients are fine after complete surgery. That was also the case in this presentation. Thank you for listening, and I am ready to...
Any questions? What is important is always to know that always there is something different that we never saw before, like the decade AF2. My first case that I saw, I also thought that was like just inverted papilloma, but I saw some unusual features. I sent for molecular, it was positive, and I said, oh my gosh, yes. So we have all these little pathologists is an art. And for you to see these little ducts, to differently classify this tumor is very good. So it's a not very unusual tumor, but maybe it's not so unusual because maybe we don't know how to make the diagnosis, and now we are learning how to make the diagnosis.
Thank you, Vania. If I may comment on that, I absolutely agree. There are sometimes complaints that we are trying to make pathology of salivary gland tumors more and more difficult by introducing new entities. But for this specific occasion, I believe that Justin was correct to describe it. That was actually collaboration with Toshita Kanagawa, putting 9 cases together. These tumors, okay, they would be diagnosed as adenocarcinoma not otherwise specified or adenoma not otherwise specified. And now if we know that it's some kind of compact maybe group of tumors, we know that this is a low-grade malignancy with most likely good clinical behavior, and new cases can be, maybe that's the reason why we are presenting such cases to the very experienced audience, and next year maybe Fred or someone else will have the two more cases. And we shall see what will happen. Thank you.
Thank you.
Okay, so we can move to the next speaker, which is Vania, and as usually, I believe that it's possible to say we do not need to introduce her. Vania is a well-known head and neck pathologist with a main interest in thyroid gland pathology. We all know her, but maybe Vania, you have been related so long time with Boston, Harvard, and now you've changed your affiliation to Justin Bishop's Place, so you are a growing star. So, Vania, the podium is yours.
I guess, thank you so much. I guess, for too many years I was in Boston, maybe too many. So Justin contacted me that he wanted me to go to UT Southwestern in Dallas, and I'll be moving the end of July. So that's why I put my new position there anyway. So let me start presenting a very interesting case that I recently had. So, you always have to pay attention to whenever you're doing thyroid or endocrine organs, age and the gender. Mostly in thyroid, you have to know the gender of the patient because man has completely different and unusual tumors than woman. So this one was a 14-year-old boy that also is unusual with a large left thyroid nodule. The patient presented with the right vocal cord paralysis, so that's how they made the diagnosis. So what we received, you can see here the morphology, but I'll go over the morphology later on. So it was a 12 gram, so it's about a little bit enlarged for a child at this age. That size is for adult person without any tumor, without any nodule. So basically when you see the section, was a diffusely heterogeneous mass that was a 4.5 centimeters, and it had multiple small little nodules within the lobe. And then a completion thyroidectomy was performed because of the tumor found, and another 3.5 centimeters, also irregular lesion, was occupying most of the parenchyma. So in the right neck dissection was performed. So in low power, what can you see here? Now I have to. You have like nests of tumor cells here and there, everywhere, but separated by fibrous bands, and you see lymphocytic infiltrate, right? So whenever you see something more like this, and you can see here in higher power, the same things. When you see something like this occupying most of the thyroid lobe, you learn in all the lectures you had in thyroid that this is called the diffuse sclerosing variant, or now is type, diffuse sclerosing type of a papillary thyroid carcinoma, right? Because it's big. But in this case, had a few other things that are unusual. So here we had going up to the surface, you had like a lot of samoma bodies here and there. And you can see even here the samoma bodies are really invading into the adjacent parenchyma. Going to higher power, you can see that it has an unusual feature for even diffuse sclerosing type. What are the unusual features? This kind of a more, I would say, more glomeruloid type of appearance, and it has nuclear features that you see in higher power later, but you see that it has nuclear features of papillary, but it's more like a glomeruloid type. So every time that you see glomeruloid type of appearance, think about something different from what you would call diffuse sclerosis simply. So in higher power, you can see the nuclear features. What are the nuclear features of papillary? They are surely well-known clearing, right? enlarged nuclei, irregular nuclear membranes, nuclear grooves. These types, they usually don't have so much intranuclear inclusions because intranuclear inclusions are mostly seen tall cell variant, so we don't see much. And here you can see well, like this really clear nuclei. But remember, to make a diagnosis of diffuse sclerosis variant or type, you need to have like squamoid metaplasia, and in this case we have. So the criteria for diffuse sclerosis is sclerosis occupying a large portion of the lobe, lymphocytic infiltrate, and squamous metaplasia. So we have everything here. And here you can see again that same nice appearance separated by fibrous tissue, nests of cells, some with a glomeruloid appearance, with some inflammation. And then when you look at this is P40. P40, you can see that there are squamous metaplastic cells within the periphery or within some other areas. And the P63 was the same thing, as you can see here. Here you can see a little bit better the squamous metaplasia, and here you see a lot of squamous metaplasia by P63. So this you could easily classify as diffuse sclerosing type papillary-thyroid carcinoma. Fine. But then, okay, this is not common in a child, and mostly in a boy, like a male patient. So you keep looking and you see some of my body is going to invading like lymphatics within the thyroid. This case was full of satellite tumor nodules everywhere in the residual non-involved thyroid. And this kind of appearance here, that I feel that this is the characteristic that we call glomeruloid appearance. This kind of appearance is being described in basically with a specific tumor due to a specific translocation, and I'll show you more. So here is the immune stain for ALK, and you would expect to have like a tyrosine kinase kind of translocation, or like mutation or anything, but ALK is very rare. The morphology, what I'm describing, what I described in this boy is characteristic of these tumors. In the ALK, we did immunohistochemistry, is always BRAF negative, while the adult type diffuse sclerosis is always positive for BRAF, basically the majority. And you see here the ALK was positive and within the tumor cells here. And then also in areas that we had like invading the adjacent parenchyma. So, and you can see here better in high power cytoplasmic staining. And we sent for moleculars, there was an ALK also translocation. And the ALK translocation was this ALK STRN fusion. So, what are these tumors? These tumors are now classified, although we introduced this type of tumors to the WHO, last WHO, because I was the one that had more experience with these tumors, we decided to wait for more people to find these lesions and these tumors and describe in the next edition, but now it was not described, it's not, let's say, officially accepted, but this is how I sign up cases like this, kinase fusion related thyroid carcinoma, kind of a diffuse sclerosing papillary carcinoma, so the clinicians understand. But why is this important? Because of a treatment, you need to treat these patients differently. And these have a very good response for target therapy. So, from all the kinase fusions, this one is the most, the rarer tumor, because it usually occurs in children, and usually is just 5% of these lesions. And what are the characteristics of kinase fusion? So there are multiple papers, it's not only my paper, but there are multiple papers described now kinase fusion. At the time of the WHO meetings, I was the only one supporting, and now we have quite a few papers, so I'm happy for that. And the characteristics are, this I just wanted to call your attention for this. Multinodular and a lobulated growth pattern. You see how multinodular it is? Very, very interesting. And this can be any of the kinase fusions. They have this multinodular growth pattern with this arborizing fibrosis type. And the other thing is very important. There is a lot of lymphatic invasion. It's like not one or two or three, but everywhere you find the lymphatic invasion, like you saw in my case that had even some bodies everywhere. So here, and specific for this is every time when you have a tumor like this, you do only the stain for BRAF is negative. So it's a clue for you to think about being something else. And the other thing is, you can see here, I think that's a very nice picture showing that it's invading even the vessels in the muscle, in the parathyroidal tissue. Okay, higher power here. You can see also the fibrosis in these nests of cells, and you see that has some squamoid type of appearance. And this can be seen in any of the kinase fusion tumors. The more specific, the one that has the glomeruloid, are the ones that usually are in children. So that's why it's important also to notice. And this one, Aline is going to like, this one is a very good thyroid tumor that I found. That looks like, to me, like secretory carcinoma of the salivary gland. And I sent for molecular, and for sure was a secretory carcinoma of the thyroid. So this exists, this is in the group of cases that we had within the kinase fusion. And this is a little bit different. Instead of having the typical glomeruloid appearance of children, this one has like the really secretion, and it has positivity for S100 and the hemoglobin, like in salivary gland. And is this a primary thyroid carcinoma, or is this a salivary gland tumor that is within thyroid? So I have my questions also, and I tell you why. Because I have been found, maybe in my life, I found maybe 3-4 cases, regular thyroid, that had remnants of salivary gland within the thyroid. So maybe in these cases that we have like this secretory carcinoma, maybe it was remnant of a salivary gland within thyroid, or maybe it's just a thyroid tumor. But this is a very interesting case also, so we have. And then we have other fusions, like this one that we have the NGR1. See like how glomeruloid appears. This also more seen in children. And then other types of mutation that had also this multinodular. And then remember, the kinase fusion can be any subtype of tumor. Can be a subtype of diffuse sclerosis, as can be other subtypes. And there is like the glomeruloid, and I like to show the right picture here, showing the in situ hybridization for kinase fusion, and you see the difference between the immunohistochemistry here, and then the in situ hybridization for NTRK fusion cases. So this is a very good diagnostic tool. Like I said, always BRAF being negative is always good to do something like this. So in the first paper, I love to make it easier to classify tumors, and this is also in my book, but I like this kind of algorithmic approach. How do you think in these tumors? And always, through this microscopic appearance that I mentioned, the multinodal lobulated appearance, the prominent intratumor fibrosis, mixed architectural pattern, frequent lymphovascular invasion, and the glomeruloid-like structures. BRAF negative, we send for molecular, and we always find something interesting. So the mutations are usually rare in children, as you know, radiation-induced. ALK is much less common. NTRK 1, 2, 3 are very common. Rearranged BRAF, not BRAF 601 mutation, but the rearranged BRAF and the others. Okay, so this one is what I use to kind of work up the case. And I think this is also in your handout. So why is it important to discover this case? Because of therapy, the target therapy that we are all doing. And the papers now more and more in the last 2 years have been coming out and are supporting this classification with the use of target therapy. So just to finalize the target therapy, we are not treating physicians, but we have to give the tools to the clinicians to treat. And here there are multiple accepted treatment. And mostly for these cases, there are like some that are very good for ALK mutation. And this patient has been treated and he has been disease-free, although he had like lymph node metastasis and everything. He has been doing very well after treatment with the kinase inhibitors. So, questions, and thank you.
Excellent presentation. Thank you so much. This is so important to listen to such cases because of possibility of specific targeted treatment. So we need to listen to such cases. Is there anybody who would like to discuss or yes, please? Adsay, please use microphone. There is a microphone. Please use it.
I can speak loudly.
Yes, of course, yes.
Great presentation, great case.
This is ready for you.
So do they wait for metastasis? If you give this diagnosis, you found the rat, for instance, do they do adjuvant regardless, or do they do the targeted therapy only when they have the metastasis?
No, they do. Now they are doing at MJ, they are doing for all cases that we find.
Even so, if thyroidectomy is done, there is no metastasis, they will give it on an adjuvant basis.
Yeah.
All right.
Yeah,
Thank you.
they are doing, and I think the follow-up of these patients has been like marvelous. There's no recurrence, and then later on, no lymph node metastasis and so forth.
But what percentage of a case like this would metastasize if not treated to begin with? I mean, it's still a lower rate, right? I mean, it's much higher than conventional,
It's higher than the convention, but they are lower than BRAF positive ones. Yeah.
Thank you.
Sure.
Thank you for this question and for presentation again. And Vanya will be so kind to introduce the next speaker.
So the next speaker is going to be Dr. Elmberger, and he's going to give us, but as you all know, he's like a very famous pathologist from Sweden, and he's friendly with all of us, and if you have any questions, anything that you want to learn from him, he's the right person to be asked. Thank you.
Thank you very much for welcoming me, and I will start with my case. Number 4, I just announced to you that I'm retired, but I have 2 different jobs. One of them is in Linköping, the youngest university of Sweden, and the other one is in Uppsala, it's the oldest one. So my case is important sinus tumor, where the detection of the etiology is good for the patient. It confers a better prognosis, and it may lead to a de-escalation of therapy. A 58-year-old female smoker with nasal pain and a blood discharge for 4 months. And on inspection, there was only irritated bilateral mucosa and a small bleeding ulcer on the right side of the septum. Clinical impression was rather benign, pyogenic granuloma and ulceration, but on biopsy we found ulcerated process in the septum, and in high power we could find a non-keratinizing infiltrative squamous cell carcinoma. So we did immunoSTEM and found it to be, this is biopsy from outside location where they did a beautiful double stain with P63 and CK5 showing squamous cell features. And another one is Ki67 and P16, both positive. So we could suspect this was a HPV-related invasive squamous cell carcinoma. And on the resection specimens there were a few other interesting features. Firstly, we could verify the invasive carcinoma component, which you see very well in the P16 stain. But on the surface of the lesion there is also a flat component, which we would very suspect is in situ component, or at least the lateral spread of the tumor. And in other parts of the specimen, they took this out with piecemeal surgery. So another area from the columella only showed the in situ component, strongly positive P16. We did verify this with molecular techniques as containing HPV type 45, high risk type. So the final diagnosis is maybe not too challenging. It's a sinonasal non-keratinizing squamous cell carcinoma with HPV association. And as we believe, also containing a component of HCl, which is a little bit more unusually. We don't regularly accept in situ carcinomas so easily in the head and neck tract. So follow-up was the piecemeal surgery. We found the cancer on the HCl, and it's very difficult to measure size, depth of invasion. Resection borders, the clinicians, they said this was radical excised, CT1, N0, M0. No sentinel node biopsies and no neck resections performed, and no adjuvant treatment. After 6 months, the patient is without symptoms and no evidence of disease, and no evidence of other HPV-related disease either. And I tried to find out if this was in accordance with the recommendations. Some centers would actually recommend that you treat this a little bit more aggressive with adjuvant radiotherapy, but it's also accepted to follow these cases closely. So when it comes to HPV-associated squamous cell carcinomas in the upper air digestive tracts, most of them are of non-keratinizing morphology. But to a surprise, the second most common type is actually the keratinizing squamous cell carcinoma. The frequency of HPV association is low, less than 10%, but the number of cases is high. So in total, the keratinizing subtypes is responsible for 10 to 15% of the HPV-related squamous cell carcinomas. Then we do find other subtypes like the papillary, adenosquamous, ciliated adenosquamous, lymphoepithelial, and even sarcomatoid variants of squamous cell carcinomas can contain rarely HPV. So it's a broad spectrum of lesions. You can basically find HPV in any type of recognized squamous cell carcinomas. And furthermore, you can also find HPV in other lesions, like in situ HCl, in multiphenotypic carcinomas, in neuroendocrine carcinomas, small cell type, large cell type, inverted papillomas, squamous papillomas, verrucas, and condylomas. An interesting feature of the sinonasal HPV-related carcinomas is that the frequency is higher dorsally. So the hypothesis is that the virus is spreading through the oral cavity and is regurgitating up into the nasal cavity. So you will find the highest frequencies of HPV-related carcinomas in the back of the nasal cavity or in the sinonasal areas, in the dorsal aspects. So this is important for several reasons. One is there is still increasing incidence of HPV-related carcinomas in sinonasal tract. There is also prognostically important information. These tumors do behave better than non-HPV-related squamous cell carcinomas. And for this reason, clinicians today consider de-escalation treatment protocols for HPV-related tumors. So they can reduce the dose of radiation, volume irradiated, less chemotherapy, less neck dissections, etc., etc. This is ongoing trials, and the practice probably is varying from center to center how much de-escalation these patients will actually get, but the movement is clear. The hotspots of HPV-associated squamous cell carcinomas is oropharynx, the most common one, as we all know. Second place is sinonasal tract, third larynx, and then we also have cases in oral cavity and hypopharynx. In essence, all aspects of the upper aerodigestive tract can contain HPV. So I want to deal a little bit about HSEAL. There are several reports on HSEAL in different subsites. This is even published in the nasal cavity, case with nasal polyp with incidental finding of HSEAL. And this is two of my cases. This is the dysplastic lesion in the anterior tongue, where we found P16 positivity of HPV-16. And this is another recent case, biopsy from the vocal cords, where we found P16 positivity and HPV-16. So wherever we look and wherever we test, we sometimes do find. So a little bit about testing methodology then. Most of us are familiar with the P16 immunohistochemistry, which do have a high sensitivity, but a varying specificity, and especially the specificity is varying in different subsites. So there may be also a need of a confirmatory stain. And nowadays, the recommendation is that we do in situ hybridization for HPV-related proteins E6 and E7. This is targeting transcriptionally active high-risk HPV with a very high sensitivity and a very high specificity. But not all labs have it. We are just taking this into our routine right now. So up to date, we use PCR-based techniques to find HPV in addition to P16 staining. So for all of you to remember about P16, this is not a specific marker of HPV infection. It's a surrogate marker, and the reason is the HPV high-risk protein E7 is interfering with the retinoblastoma pathway, and then you get a upregulation of the P16 expression. But this is not the only reason to get an upregulation of P16. So there are lots of various algorithms how you do when you get a P16 positive or a P16 negative staining, but these are a little bit outdated today, so I will not spend too much time in these algorithms. But the pros and cons with P16 is high specificity, but low specificity in essence. If you compare the test performances of HPV in two subsites, like the oropharynx and the sinonasal cavity, we will see that the P16 sensitivity is equally high in both subsites, but the specificity in oropharynx is about 91%, but it drops dramatically in the sinonasal tract towards 80%, and that means that the positive predictive value is decreasing from 93 to 56%. So it's a very good test in oropharynx, but it's not a good test outside oropharynx. So the technique that is now preferred and recommended, the in situ hybridization for messenger RNA E6 and E7, there are various commercially available tests of this one, and there are also some other publications where you combine the in situ hybridization stains with the immunohistochemistry. Maybe you are familiar with the gene protein test for HER2 from Roche, but you can do the same here. So you can add cytokeratins to see the tumor, and then you have the in situ to see the E6 and the E7 staining. So the pros and cons of this test is high accuracy, high sensitivity, high specificity, high prognostic value, can be performed on automated platforms, but it's a little bit more complicated to perform. Not really, because you still use the automated platforms and there are commercially available tests, but still not everybody is doing it today, and you need to validate the test. So I will skip this in the interest of time, but also mention that still the reference technique, if you have problematic outcomes and you want to check it, NGS is still the reference technique. It will detect any type of HPV virus with the ultimate sensitivity and specificity. So the new recommendations are from CEP now is to test all sinonasal squamous cell carcinomas with HPV testing, and they want you to go directly to the in situ technique. So, conclusions. HPV-associated sinonasal carcinoma is a distinct subset. Non-keratinizing morphology is common, but all variants can occur. It's increasing in incidence, and it has prognostic value. And for this reason, patients can have de-escalation therapy protocols. I also would like to emphasize the possibility of in situ lesions of H-cell-like morphology. And we find it in many different sublocations of the upper air digestive tract. And it's very practical when you have a piecemeal surgery to do the P16, because these lesions can be very, very subtle. But with the P16 stain, you will easily detect them and easily find them. And as the single assay of recommendation today is to do the in situ hybridization for E6 and E7. But many labs can still use P16 as a screening test, but please remember it's not a very specific test outside the oropharynx and not in the carcinoma of unknown situation in lymph nodes on the neck. So personally, I would recommend a very generous testing for HPV in all subsites of squamous cell carcinomas dysplasias, and to cite the famous, is it Canadian or an American? Wayne Gretzky. You miss 100% of your shots if you don't take them. Thank you very much.
Thank you. A great case and a great, summary of what we need to do. I don't know if you all do in situ hybridization, but it's like so important for us to have even the specific which one P16 positive, and then it's HPV 16 or 18 or 33, because usually the sinonasal are 33, right? So it's something very good. But anyway, questions, please. No questions? Everybody loved his
Thank you.
talk, so thank you. Now we have Dr. Saul.
Okay, thank you. We'll move to the next speaker. We are a little bit over the time schedule, so as hosts of this, we should be fine with 15 minutes of presentation. So the next speaker is Martina Bradová from our department. Excuse me, I have to introduce her because she used to be my PhD student, working on head and neck pathology, particularly secretory carcinoma and others. But well, now she is an independent scientist, associate professor, and she is really very nice head and neck pathology. So Martina, the podium is yours.
Thank you very much, Alana, for a lovely introduction, and good morning to everyone. I'm very pleased to introduce case number 5. So here is, it was 47-year-old man with several years lasting swelling in the right part of the gland. Sonographically, there was some description that there is a cystic lesion which was well circumscribed, and therefore the clinicians performed suspicious for Barton tumor. Macroscopically, the resected specimen was quite fragmented, and there was something which could be called as some cavity inside with grayish-white tissue in its center. So the low magnification showed quite well circumscribed lesion from the surrounding parotid gland. The cystic cavity was not so well preserved because of the fragmented tissue sample, and you can see that the tumor was quite well separated from the surrounding comatose atrophic parotid gland by this fibrous pseudocapsule. There were some hyalinization and sclerosis in the stroma of the tumor as well. So the tumor was composed of 4 basic types of cells. In this picture, we can see the first 2 types of cells, clear cells, and all cells with vacuolated cytoplasm, but empty cytoplasm, and the cells which show the oncocytoid features or oncocytic type of cells. The tumor grows mostly in a solid fashion, but there were occasionally also some areas which resemble some tubules, and also areas which were microcystically characterized and arranged. So here you can see the 2 basic types of cells which were predominant within this tumor, so clear types of cells and also oncocytic type of cells. So here is the hyalinization, and again the basic 2 types of cells, but here we can see also a few other cells which were very scattered and which are, I don't know, not sure. Yeah, here. Here is for example one. That's okay, I will take another sample and another picture. It's more pronounced in here. Here we can see that there were some mucose differentiated cells with mucose vacuole in the cytoplasm, and again all of these cells were quite well developed, mostly monomorphic with visible nucleoli. In here, these cells were also responsible for development of such mucous pools within the tumor. And the last type of cells were these cells with basophilic zymogenous granules in the cytoplasm, which are characteristic especially for actinic cell carcinoma. These types of cells were not predominant. They were responsible for 5 to 10% of the tumor volume and not more. They were sometimes accumulated, but sometimes very dispersed, almost not visible. In here it's again same. And I think that the histology is quite variable and confusing, so now it is time for immunohistochemistry, but it will be also confusing as well, unfortunately, because the tumor showed the positive expression of P40, P63, mostly in a diffuse manner, but occasionally it seems that it makes some biphasic expression, but it was just from low magnification. As one other protein was positive in an intermediate fashion only in one small focus of the tumor, but it was mostly very weak at the periphery and mostly negative. Suster highlighted very well the microcystic architecture, and therefore some of the differential diagnosis was also secretory carcinoma. But unfortunately, we performed DOC1, and DOC1 was positive despite the quality of the sample, so it was also positive in tumor cells. We performed pulse with diastasis, and it expressed well in the cells with basophilic zymogenous granules in the cytoplasm and as well in mucous cells. Other negative markers were smooth muscle actin, H-calcitol, CD10 calponate, and also these surrogate markers for NR4A3 and NR4A2 genes. Hemoglobin was also negative, and the proliferative activity was quite low. It was only 1%. So when we consider the architecture, the type of cells, along with immunohistochemistry, we prepare a differential diagnosis which consisted mainly of secretory carcinoma, actinic cell carcinoma, and mucoepidermal carcinoma. When we want to see secretory carcinoma, especially in such a low-grade type, then the tumor is usually microcystically oriented, and this tumor was predominantly solid, but it never mind, sometimes it is also solid. But we want to see as one other protein strong expression along with hemoglobin and Suster expression, but hemoglobin was negative. We want to see also negativity with DOC1 and B63 and B40, but unfortunately both of these markers were positively expressed in our tumor, and we also want to see that there are no zymogenous granules which will be positive. So another option, thanks to the presence of actinic type of cells, those cells with basophilic zymogenous granules in the cytoplasm, so the differential diagnosis is also actinic cell carcinoma, which should be positive with DOC1, and usually is also positive with one of these markers, NOR1 or NUR1 and SOX10. The tumor should be P63 and B40 negative, and as one other protein is expressed usually only in the intercalated type of cells, but mostly it's negative throughout the tumor. And finally, mucoepidermal carcinoma, which is a tumor with the triphasic morphology of tumor cells. There are epidermal type of cells, intermediate and mucinous cells, but we did not see any epidermoid type of cells within this tumor. But this tumor shows the mucinous cells even scattered, which were Pasi positive, and the tumor cells were P63 and P40 positive. According to WHO classification, mucoepidermal carcinoma should be Suster and S100 negative, but that's only for the classical variant, because we know that there are many other mucoepidermal carcinoma variants, and I on purpose omitted one variant. That some of these variants might be also Suster S100 positive, for example, the oncocytic variant of mucoep. So when the immunohistochemistry and also histology is confusing, I think that this is the time for the molecular genetic investigation. And here we are. We have found CRTC1 MAML2 gene fusion within our tumor, and now I can reveal the diagnosis because I think that most of you already know it. So this is, our tumor was mucoepidermal carcinoma, and the variant is mucoacinar carcinoma, which is quite rare variant because it was described only in 11 cases in the literature. These authors around Raja Sitala collected these tumors with very specific morphology or overlapping morphology in between. It's something in between actinic cell carcinoma and mucoepidermal carcinoma. They have found that most of their cases were of low to intermediate grade, and only one case was of high grade morphology, and the acinar component was less than 5 to 10% of the tumor volume. These authors have found that they have only 3 cases with full follow-up, and they think that these variants are related to good prognosis. However, mucoacinar carcinoma is not a typical prototype of mucoepidermal carcinoma because it does not contain any epidermoid component, and it could be very confusing. So the differential diagnosis is quite spread and also related to secretory carcinoma and actinic cell carcinoma. The immunohistochemistry for their cohort showed that most of their tumors which were investigated were positive with DOC1. Only one case, it was case 10, which was negative, was the case of high-grade morphology. All their tested cases were positive for STOX10, and most of their cases were positive focally for NR4A3 surrogate marker, which is surrogate marker for acidic cell carcinoma. They perform molecular genetic investigation, and they have found that MAMALA2 rearrangement was positive in all cases, while NR4A3 rearrangement was negative in all tested cases. Where else we can find a cell type of differentiation, because we in the past only acidic cell carcinoma was considered to contain this type of differentiation, but now we know that mucoacinal carcinoma also may contain such granules in the cytoplasm. And don't forget about sclerosing polycystic adenoma, which is now considered to be true tumor and not a non-neoplastic lesion or sclerosing polycystic adenoma has somehow a little bit different types of these granules. They are more magenta, not so basophilic, and they are very coarse. Now I would like a little bit to talk about variants of acidic cell carcinoma. They are not well listed in the WHO classification. They are a little bit separated according to architecture, according to potential high-grade transformation, and also according to the predominant type of cells. There are some acidic cell carcinomas which can have clear cell and vacuolated type of cells, but I would like to highlight only one variant which was described only in 2 cases in the literature, so it's questionable whether it's a variant itself or just some strange tumor, but the findings are quite well for detected it as a variant of acidic cell carcinoma. So the squamous glandular variant was described again by Raja Sitala, and this tumor is again something in between mucoepidermal carcinoma and acidic cell carcinoma. It contains a very pronounced squamous proliferation with foci of serous acinar differentiation, and there are very rare mucous cells also. This tumor is positive with cytokeratins, DOC1, P40, and especially for NR4A3 gene, NR4A3 immunohistochemistry, and they have found by molecular genetics NR4A3 gene rearrangement, and MAMALA2 was negative. And finally, the last case of this acidic cell carcinoma with these squamoglandular features contain also high-grade ARAS, which has heterologous elements of chondrosarcoma. The tumor was morphologically very diverse, contained different foci of and different architectures, and especially there was one small focus of conventional acidic cell carcinoma that led the authors to perform immunohistochemistry for NOR1 and also for the molecular genetic investigation, and they performed an NR4A3 phage which was positive in this tumor, along with the sequencing and findings from the sequencing of TP53 and other genetic mutations in both the acidic cell component and also in those high-grade ARAS. So, I would like to go to the conclusion, which will be very short. Mucoacinar variant of the mucoepidermal carcinoma shows usually low to intermediate grade morphology. It's usually growing in a solid fashion, so the grading system for mucoepidermal carcinoma is not applicable again for this variant. It has predominant clear cell and oncocytoid cell phenotype with serous acinar differentiation, which is quite not specific to acidic cell carcinoma because it can be found in other salivary gland tumors. The morphology, along with SOX10 and DOC1 expression and occasionally isolated NR4A3 gene expression, has to be taken in mind because it is something in between mucoepidermal carcinoma and acidic cell carcinoma. And when the immunohistochemistry and histology is not good for us, we usually approach, and it's recommended to approach to molecular genetics, and molecular genetic result led us to the diagnosis of this variant of mucoepidermal carcinoma, so mucoacinal carcinoma. Thank you very much for your attention.
Thank you, Martina, for absolutely wonderful presentation. We enjoyed a lot, and I believe that you liked the example how salivary gland pathology still presents a spectrum of unexpected combinations of findings, and so all the time. This is after WHO classification. We are expanding our findings after fifth edition. Martina, very nice presentation. Is there any question, comments? Yes, please.
Well, as you know, I do electron microscopy most of the time. I always wondered how or why we consider acinar cells only the simultaneous granules, because we have acinar cells which are mucus. So you would expect to find mucinous granules also, which is probably is that the case.
Thank you for comment. Do you want to tell something or comment something? I think it's a really good point that we have acini that are either composed of serous cells or mucinous cells. So this is the explanation that we can have such a hybrid or tumors sharing the presentation. Martina, thank you so much again.
Thank you.
So we are going to continue now with Dr. Michal. She's going to present case number 6.
Thank you again. I'm back. I will be fast. And I believe that you will find the case quite easy. The tumor was not located in salivary gland tissue, but it was a tumor of left nasal cavity of a 40-year-old male patient who presented with epistaxis, fullness of nose, and the tumor was quite large, about 18 millimeters in greatest dimension. This is consult case again, and the tumor has been removed in fragments, as you will see, and when the preliminary biopsy was taken and diagnosed, there was another complementary ethmoidectomy performed with clear surgical margins, and the tumor was sent for second opinion, but at the time the tumor received radiotherapy and seems so. I asked for follow-up because it's not originally my case, but the case from France, and the patient seems to be still okay, but the follow-up was at the 17 months after the first diagnosis, so we shall see. The tumor was removed, as I said, in fragments. Here you can see very well fragmented material, which is the case always in sinonasal. The diagnostic difficulties, we have limited material, fragmented material, but high magnification can show you something. There is a respiratory epithelium on the surface, and the tumor itself is mostly solid at the first glance. High magnification shows also some papillary structures or cystopapillary structures, but majority of the tumor is quite solid. High magnification of the other area may show you. You can appreciate presence of necrosis here, and even more, some parts of the tumor were really solid with a high-grade morphology and with a comedo-like necrosis in the centers of somehow organoid arranged solid and maybe microcystic a little bit pattern. High magnification may show you here something interesting close to the fibrous septa. There was a clearing of cytoplasm and a little bit again palisading of the tumor cells. High magnification again shows you the cells are polymorphic, however quite regular. The nuclei are roundish, nucleoli distinctive, quite centrally located. So generally the tumor is like mild, bland looking. Again, question mark is suggesting your diagnosis, but we need immuno. So the tumor cells were diffusely positive for cytokeratin 7. However, negative, which was not expected, for CK20 and CDX2. So it seems that it brings us close to the diagnosis of non-intestinal type adenocarcinoma of sinonasal tract, non-ITAC. But here we have something which we do not like to see, and that's a diffuse, strong SOX10 positivity, as you can see in both parts of the slide. And there were even some S100 positivity, so we started to think about something else, and of course we tried DOG1, NOR1, which is not mentioned here, mammaglobin, STAT5, and these were negative. So if you are familiar, that should be positive in secretory carcinoma, seems so. And even more unusual feature for secretory carcinoma, if we consider this diagnosis, would be this strong P40 positivity and P63, that's the same, and mostly seen, of course, in abdominal layer close to the. It seems that the tumor is like biphasic. So that's a summary. On immunohistochemical examination, as you saw, we did provide evidence of positivity of P40 and P63, which highlighted abdominal cells. The same finding was with cytokeratin 14, but the luminal cells were negative for these markers. Well, the cells were positive for S100, SOX10 somehow, and diffusely positive for cytokeratin 7. Moreover, there was GATA3 positivity in nuclei and PANTAC immunohistochemistry, and there was a mixture because we know that sometimes there is cytoplasmic positivity, but nuclear positivity is quite pushing us to secretory carcinoma. But immunoprofile is confusing. There was pretty high proliferative activity with approximately 45% of positive cells with MIB1 Ki67 within hot spots even higher. So definitely high-grade something in sinonasal tract, which is a little bit similar to high-grade transform secretory, but not completely. So we went for molecular testing, and that's the result. So we found ETV6 gene break, and we found ETV6 NTRK3 fusion. So could it be secretory carcinoma? Not really. So our diagnosis, and I'm going to try to sell this diagnosis to you, is high-grade sinonasal adenocarcinoma, non-ITAC with ETV6 NTRK3. And you may be surprised because, of course, it's a strange diagnosis, but we published it. We had 2 cases, both coming from France, from our very good friend, whom I will not name, but I can tell you who is that. But basically you can see her name or her names in the published paper. So we had 2 cases of identical tumors in nasal cavity. One of those cases is actually the one I offered for this seminar. So we published it. It's surprising maybe to you to hear such presentation from me, because ETV6 and 2K3 is canonical fusion for secretory carcinoma. Everybody knows. Even I would like to point or attract your attention to this paper, Mammary Analog Secretory Carcinoma Mask of Nasal Cavity, which was published recently, first author Martina Bradová, who presented before me. So it's possible to have secretory carcinoma in sinonasal cavity primary, but it looks different. So this is a real case of secretory carcinoma of nasal cavity, and you can see very typical features, secretory activity. Yes, the cells which are regular, and the immunoprofile is typical for secretory carcinoma, which was not the case in this presented one. Okay, so that's the first step of the story. The second step of the story has been a paper which was published 2017, if I'm not mistaken, and I was very suspicious when Simon Anderson sent me the cases of low-grade, non-intestinal type sinonasal tumors, and he was proposing the idea that it's a sinonasal low-grade non-ITAC with ETV6 gene rearrangement. I told him, no, it's not, it must be secretory carcinoma. But basically he was right, and we finally agreed with Michal and published together the paper which presented examples of low-grade ETV6 gene rearranged sinonasal low-grade adenocarcinomas, not secretory carcinomas. And these are two papers that has been published, and that's how the tumors looked like in the paper. So really not very secretory carcinoma or mask-like, low-grade non-intestinal tubulopapillary adenocarcinoma with positive staining for S100 protein and some DOP1 staining in luminal surfaces. But, well, so that was published. But it was not published to have such cases with high-grade morphology up to our paper with Martina Bradová, which I presented earlier. So in conclusion, I'm trying to show you or trying to pursue you that the case should be diagnosed as high-grade adenocarcinoma non-ITAC of sinonasal tract and not high-grade transformation of secretory carcinoma, despite the fact that there is a recurrent ETV6 and 2K3 fusion which is canonical for secretory carcinoma, but immunoprofile, behavior, and histology, morphology is different from secretory carcinoma. So that's my conclusion, and I'm thankful for
Quick question. Was the P63 the abdominal cells decorating the whole tumor? So could it be an introductive process?
Quite good. It could be. It could be. However, it's more or less biphasic than introductal. It could be. True. Yeah.
That appears to be invasive areas, right?
Sorry?
Appears to not have some P63.
Secretory carcinoma should be devoid of P63 and P40, with few exceptions of in situ, maybe foci, which can be seen, but generally secretory carcinoma does not produce P63 and P40 staining. But this point is quite possible, but basically I'm speaking about biphasic tumor.
Okay.
Yeah, I believe so. Now let me start the second part of head and neck pathology session. Please, it's time to start.
Let's go.
Let's go, let's go. The first speaker is Elmberger, and he's already prepared to start his talk.
I'm well introduced, thank you again. Welcome after coffee. My second case, number 7, is a tonsillar tumor that was hard to diagnose on biopsy, where resection helped a lot. And an interesting and unexpected predictive markers were found due to initial diagnostic uncertainty. Again, good soldier Czech is showing his tonsils. The 60-year-old previously healthy male presenting with a rapidly growing right-sided neck tumor. The 1 month history, ET status reveals suspicious tumor in the right palatine tonsil. So they performed small tiny biopsies from the tonsil and a core biopsy from the neck. And they looked more or less the same when you come to the tumor component. It was a moderately differentiated adenocarcinoma here in the tonsil and here in the neck. So what could you consider here? I mean, you could consider this as a surface-derived tonsillar adenocarcinoma with metastasis to neck node, or salivary gland carcinoma from the oropharynx with metastasis to the neck node, or salivary gland carcinoma from the parotid with metastatic to the oropharynx, or a carcinoma of unknown origin with metastasis both to the oropharynx and the neck node. So what did you do? Yes, it was specific, not much. CDX2 was mildly positive, but the surprise was it was HER2 intensively positive, P16 intensively positive, P53 wild type tumor and a high proliferation rate. So here are the CK18, P16 and HER2 stainings. And we did molecular on this one. We performed HER2 gain of 40 copies, ATM loss. It has a low tumor mutational burden of 1.61, M stable, and also HPV type 16 detected. So our preliminary diagnosis after these biopsies and unancillary techniques were very unusual adenocarcinoma with both HPV high-risk association and HER2 amplification, and we really didn't know where it came from. However, the presence of high-risk HPV was felt to favor the primary mucosal-derived oropharyngeal carcinoma, and we recommended excision for both diagnostic information and therapy. So I had to look up which organs do you find HPV high risk or HER2 amplification, and the answers are cervical adenocarcinomas, head and neck adenocarcinomas of the oropharynx, lung adenocarcinomas and anal adenocarcinomas. But I wasn't able to find any single case with both HPV high-risk association and HER2 amplification. So the resection specimen made it actually a little bit more easy to classify this tumor, because here we could see 2 different components. One was squamous cell component, and the other one was adenocarcinoma component, and they were separate. P40 was positive in the squamous cell lesion, P16 was positive in both, and HER2 was positive only in the adenocarcinoma part. So our final diagnosis was tonsillar adenosquamous carcinoma with HPV high-risk association and HER2 amplification. Additional findings, 14 millimeter sized. Both components were HPV associated, adeno were HER2 positive, and in the neck resection specimens we found 5 metastases, and they were only composed of HPV-related adenocarcinoma. 3 margins, PT1, N1, and patient received radiotherapy full dose, and after 8 months alive without disease. So where do we find adenosquamous carcinomas in the body? And this is according to the SEED database. The most common location is lung, cervix, pancreas, and on fourth place is head and neck. And then less common gallbladder, colorectal, esophagus, stomach, and breast. So the spectrum of adenosquamous, adenocarcinoma, and squamous cell carcinoma is quite different in different organs. For some reason, I don't know. So in the head and neck relationship of HPV in adenosquamous carcinoma, there are very few publications. This is one of them. And they found high-risk HPV in 3 or possibly 4 of 18 adenosquamous carcinomas. And it was defined as transcriptionally active with P16 positivity and molecular identification of HPV high risk. So it's unusual with adenosquamous carcinomas and it's even more unusual with HPV-related ones. What significance does this bear? The adenosquamous cell carcinomas of the head and neck usually has worse prognosis than usual squamous cell carcinomas. And the differential diagnosis of adenosquamous carcinomas in this location is generally it's mucoepidermoid carcinomas and it's acantholytic squamous cell carcinomas, maybe some variants of adenoid cystic carcinomas, and basaloid squamous cell carcinomas. Some salivary gland carcinomas might enter the differential as well. So the main differential diagnosis is generally with the mucoepidermoid carcinoma. This is the table directly from the WHO classification, comparing the two entities. You can probably read it up for yourselves later on to save some time, but this is what you usually think about. And the clinical pathological importance of finding the HPV-related tumors generally in oropharyngeal tract is it's a different epidemiological situation. It's younger people, it's increasing incidence. The risk factors are generally sexual number of partners, plus minus smoking. And stage is usually small, primary, large metastatic tumors. And it's presumably originates in the crypt epithelium without evidence of dysplastic lesions in the surface epithelium. And the predominant morphology here is non-characterizing squamous cell carcinoma. We don't apply grading. P16 is a good screening tool, and survival is better than the non-HPV related tumors. So I would like to think a little bit about the association of HER2 or HER3 as therapeutic targets in head and neck cancer. I've seen these tumors for a while, and we have them on the multidisciplinary rounds. And the clinicians are very reluctant to treat them. And the reason is there are very few studies. This is a summary of the studies, and they are generally only phase 2 studies, very few numbers, and they never finished them. So really there is not a very hard evidence to treat them. But you know, in a case like this with far metastasis to the neck region, and they had more than 40 gene copy numbers of HER2 and our NGS didn't show any other driver mutation in the tumor. I think when this patient has next metastasis, I will be very aggressive at the clinical round, so they should try the HER2. And this is our molecular pathologist's answer to it. They have a ESMO scale for grading the clinical actionability of molecular targets. And she is now helping me to review the status of the HER2 amplifications. It's not very simple. And I don't know if they will treat it. So the evidence situation is not much. For salivary gland tumors, there are some evidence that they respond. For non-salivary gland tumors, it's very limited findings in the literature. So my take-home lessons here is that this is a very unique case of a tonsillar adenosquamous carcinoma with the dual risk factors association of HPV high risk type and HER2 amplifications. I believe it's very rare, and I could not find any other case. Maybe you have some like yours. You tell me. So this is aggressive tumor. HPV is associated with the positive prognostic and predictive factors and can lead to de-escalation therapy. HER2 positivity is prognostically an adverse factor, but a promising but underutilized target of treatment, with a growing evidence of support for treatment. And my take on this is, it was a very difficult situation when you have those two tiny biopsies to come up with a conclusive classification of this tumor, and that always drives our clinicians nuts. They always want definitive answer to type, origin, blah blah blah. But you know, when you really don't know for sure, it's always worth asking for resection specimens of more tissue. Sometimes it will be evident when you get the whole piece out of it, which is impossible to solve on a small biopsy. Differential diagnosis of adenosquamous carcinoma is quite broad. You need to utilize immunohistochemistry in situ, sometimes even molecular testing. And again, repeat here, the golden standard for detecting HPV is now in situ hybridization, E6, E7. And we routinely, of course, do not perform these broad panels of immunohistochemistry and viral testing and molecular pathology on a straightforward case. So we really do not know what is the epidemiological situation. If we would screen all these cancers for HER2 now, maybe we will find a lot more positive cases. But of course, we don't know if it's worth it or not. So my PhD mentor, his name was Gustav Wallner, came from Hungary. He had two signs on his desk. This was one: chance favors the prepared mind, and it's by Louis Pasteur. The second one I don't show you, but it's from Einstein, and it's stated that a clear desk is the sign of empty mind. His desk was a total mess, but his mind was like a photographic memory of everything. To my dear mentor Gustav. Thank you.
Thank you, Göran, for presenting such a unique and difficult case, and I would like to start the discussion if you want to comment on the case somehow. Is there any interest in commenting? What happened to the patient actually? Did he receive
No, I checked just before coming here. She is doing well. No signs of additional no signs of tumor yet, but it's only 8 months out after diagnosis and radiation therapy.
Yeah, okay.
So I keep my eyes on the case.
Yes, thank you.
So we are going to do the next case then. Dr. Petersson is going to give us present the case number 8.
Just in parenthesis, we do treat salivary gland carcinomas in Singapore with HER2 amplification regularly. The first case we had was actually a salivary gland carcinoma of the lacrimal gland, which was unresectable. But the core biopsy and HER2, it was quite some years ago. It's just an anecdote, but it's a good one. So unresectable, treated with chemo plus Herceptin, and then we didn't resect, and we couldn't find one viable tumor cell. Only fibrosis and reactive changes. So now that, but they were a bit skeptical in the beginning. Anyway, so my case is a 77-year-old man. Hypertension, hyperlipidemia. He presented with eye problems, ptosis, and double vision, and and there was limitations of ocular movement. The clinical examination in MR showed a 3 centimeter plus mass, you can see there, quite well delineated. And they went in and debulked it and sent some tissue for frozen section. And this is the frozen section piece. There's something red here and something blue, but it's not cherries and blueberries. So 3 different high power fields here you can see, looking the same. Some epithelioid cells with some basophilic stringent material, don't know what. I didn't do the frozen, but the frozen pathology, okay, there was a lymphoid aggregate there. And if we go high power, it's dominated by small lymphoid cells. There is a little bit of plasmacytic, plasmacytoid differentiation on the touch prep. Yeah, I cut the touch prep. Yeah. So you see there is a little bit of, I don't know if you can see this magnification. This shows a little bit of a more of a mixture of slightly larger cells, but predominantly small cells, and some plasmacytic, plasmacytoid differentiation. So was this the frozen section pathology? Why? Yeah. So he backed off and said, this is lesional, I have no clue what is going on. Wait, because we sent to the people who deal with these strange things. He's a renal pathologist. Anyway, so these are permanent sections now, and it's more of a tissue. And the red and the blue here nicely mixed. Very sharply demarcated blue lymphoid aggregates, and all that red gas here. So we do again 3 different areas, high power, looking the same. You've seen it before, it's a no-brainer. If you don't see it, it's quite a good case because you will recognize it the next time. Okay, so these cells on IHC were positive for CD163 variable intensity because the cytoplasm is smack full with some stuff. And the lymphoid aggregates CD20 positive, CD3 reactive T cells, CD5 the same. CD10 is negative. Somewhat expanded dendritic meshwork with CD21. LGS67 shows. I want to go back. Oh. Yeah, so the LGS67 is low. Okay, so here we are. CD138 shows that there is some plasmacytic differentiation in the sort of peripheral cells, insinuating the cells between those macrophages there. And they show lambda restriction on cytohybridization. To the left is lambda, to the right is kappa. And light chain immunohistochemistry shows that lambda is present in those macrophages, kappa is not. So this is crystal storing histiocytosis associated with a low-grade lymphoma. I signed up the case, I thought it was marginal zone lymphoma, model lymphoma, but they wanted to check, so it's not a lymphoplasmacytic one, which it was not, by this my MYD88. Yeah, we thought it was a pretty case, so we wrote it up. And also we haven't seen any published data on crystal storing histiocytosis and frozen section, which looks very, very different from the HE. So the majority, 90+% of CSH are associated with B-cell lymphomas or plasma cell proliferation, myeloma, plasmacytoma, MGUS, but the crystals are then composed of parts of or the whole pathological immunoglobulin, but there also exist non-IG related associated cases of crystal storing histiocytosis. I've never seen one. CSH in the setting of lymphoproliferative diseases can occur in multiple sites or like a mass lesion, as in our case, and most commonly in the head and neck region. Wide age distribution, but more in the older population. Yeah, I mentioned that you can see it in other settings as well. together with Charcot-Lyden crystals, patients with mastocytosis or conditions with eosinophilia. Clofazimine, a drug, can give rise to these silicosis and hereditary cystinosis have also been associated with CSH. But as I said, mostly it's lymphomas, myelomas, blastocytomas. And interestingly here, we couldn't see those crystals on frozen section, and possibly the in vivo dispersed abnormal part of the pathological immunoglobulins may aggregate and become more conspicuous after fixation. So it may be a fixation-related phenomenon. Yeah, so whenever you see this, of course, the message is a long sentence, you have to hunt for an underlying plasmacytic or lymphoid neoplastic process, because you can also precede the diagnosis of lymphoma. Differential diagnosis, well, if you've seen it once, it's an easy thing. If not, you will go perhaps through the route of rhabdomyomas, granular cell tumors, oncocytomas, everything that is red, and also pseudotumors like Gaucher's disease, granulomas, malakoplakia, etc., etc. Treatment so far for those ocular cases in the literature with lymphomas, low-grade lymphomas, with radiation or excision or combination has been very good. Yeah. Okay, so that's that. This is a view from one of the buildings in Uxmal, which is a post-classic Maya site. Here you can see one of the pyramids. This is a whole site with multiple pyramids. And to the right here you can see down there's a fellow with a big nose, and you see the eyes and the teeth. And there again, this is Czech, which is the Mayan equivalent of the Aztec god of Tlaloc, which is the god of rain and thunder. Okay, done. I'm on time.
So, I have a question, just because of interest, like you said, when I look at the first slide, frozen section, I said, oh my gosh, what's that? There's some kind of a funny thing in these cells. But how come for you was important to look at the plasma cells? Because basically they're not very prominent in the slide that you showed. I mean, there are some plasma cells there, but it was not very prominent.
Yeah.
So you thought initially that was a lymphoma type?
Yeah. No, I knew about this association with multiple lymphomas and crystal storing histiocytosis. If you've seen one case, the next case is like a gestalt. You will recognize it. Yeah, that's
but in this case, there were not many plasma cells. That's
no. This is a multiple lymphoma with focal plasmacytic differentiation.
The focal plasmacytic,
which can happen. You see?
Yeah. Yes, sir.
You showed the imprint slide.
Mm-hmm.
Was it stained with Papa Nicola or Ginza?
I can't recall.
Because I've seen these cases in Ginza stain and they look beautiful. You can really
I'm not a cytopathologist, but I didn't do the frozen, so I don't know what. I
it
don't
could
know.
have additional value to do an imprint stain for the frozen. We always did at the Karolinska.
Sure, but the important thing here is conceptually to make the sort of leap from lymphocytes and plasmacyte or plasmacytic cells and those large abnormal histiocytic cells with funny things in the material. Those go together, and this is like a combined gestalt. So now you've seen it, the next time is easy. And even now you have seen it on frozen sections, so you can be the hero of the day.
Thank you.
Thank you for a wonderful case. I really enjoyed it. Yes. We'll remember forever. Now it's my pleasure to introduce again Vanya. The next case is yours. We are very good in time. Thank you to all of you.
And I will try to be really good because this one is straightforward and it's a beautiful case. And I wanted to share with you just because, you know, we are always thinking all the molecular, we're thinking always in so many things, and how about putting all things together whenever you see an H&E? So this is basically one very interesting. So again, this is a 40-year-old but male patient with multinodular thyroid, right? We got the case is goiter. Oh, goiter, that's it. So They're microfollicles, macrofollicles, and you can see here that I like very much to see. You see that you have like one nodule here, one nodule here, and in between you have the compressed thyroid. So this is unencapsulated, there is no capsule, has morphology exactly like morphology of an adenoma, right? But with no capsule, compressing one and the other. And I just wanted to highlight the higher power. You see that the nuclei are well organized. There is a really nice organization in each follicle, and some are large with like darker colloid, older colloid. So this is called the adenomatous nodules, right? So the adenomatous nodules are like when you have non-encapsulated nodules with these small follicles in the very nice, architecture showing all these follicles with a very nice round oval nuclei. And every time, and I just want you to all think about this, every time that you see multiple adenomatous nodules, which is thing you have to do? P10. So look at this beautiful stain here. So you see that the follicles are normal, there is not malignant, no mitosis, no pleomorphism and so forth. And here you can see the same follicles with a negative P10 staining, while the endothelial cells are positive and the cells in between the fibrovascular core are positive. So this patient had some adenomatous nodules, like I showed you. And then in between these nodules, there are also nodules that had macrocysts or macrofollicular areas. So you can see some like more macrofollicular areas, and I had also some what we call centripetal papillary growth. So you have a big macrofollicle with this centripetal papillary growth, and this also was the new term accepted by the WHO in 2022. We discussed that this is a characteristic finding of at least 2 familial syndromes. So the centripetal papillary growth is seen in 2 syndromes, and one is P10 hamartoma tumor syndrome, the other one is Dicer-1 syndrome. So you always have to think about this. So just to show here is the follicle, the lumen with the colloid, and you have like some papillary growth inside, but then you have the fibrovascular core. Sometimes the fibrovascular core is also thickened. And here's a good example that you see macrofollicles instead of being microfollicles like in the first slides. Here you have macrofollicles with what we call centripetal papillary growth. Before, people didn't accept the papillary because of papillary thyroid carcinoma, so this centripetal papillary growth is very important for diagnosis. And here you can see a little bit in this area here, a nice micropapillary growth within the large follicle. And this is my favorite picture that I took from a nice case that I thought that, this was a large macrofollicle that had the characteristic papillary growth. So it's a growth of papillae inside of the follicle, and you see that the nuclei are very well organized. They are not piling up, there is no atypium. And this patient, look at this, this is very important. You start to see more things, pay attention to more. So this patient had also a classical follicular adenoma. As you can see here, is encapsulated, right? So the nodule is small, but is encapsulated. I usually do levels when I see a small lesion like this, because sometimes you have even capsular invasion. So had this small follicular adenoma. Then he had another follicular adenoma, what we call eggshell type calcification. And then another nodule. And you have to classify different nodules, right? So then the other nodule was a carcinoma. And you can see that there is, the capsule coming here and here, and there is disconnect, and the tumor is growing outside. And there are a few other areas, just to show you. So I don't need the more stains, I did only one stain, right? I did the P10. So the patient has Cowden syndrome, P10 hamartoma tumor syndrome. And everything that I described in the microscopic fields match exactly what the P10 patients have. So the final diagnosis is here. So I had a minimally invasive follicular thyroid carcinoma, I had a small classic papillary carcinoma, thyroid follicular adenoma, I had 3 follicular adenomas, and then follicular nodular disease with adenomatous nodules and the microfollicular nodules, and besides that had lymphocytic thyroiditis. So always remember, this is my favorite differential diagnosis. Now more and more we are seeing more familial syndromes, and we are making diagnosis of familial syndromes, just describing everything and learning about everything. So always in sporadic follicular carcinoma, you have a normal background thyroid that you don't have multiple nodules, and it's usually a single tumor. When you have like a multicentric, the background is usually with a lymphocytic thyroiditis, usually it's familial. But now making life easier for us just to show that a familial, the other thing, the terminology we changed it, and mostly thanks to me because I love familial syndromes, as you know. So, like we changed it in the WHO because before was nodular hyperplasia, and we know that these are not hyperplastic, they are neoplastic, right? They are monoclonal. You saw the immunostains, everything loses P10, let's say. So we changed the term to follicular nodular disease. So please don't call anymore follicular hyperplasia. So follicular nodular disease is a new term, is accepted, and the etiology you see here is usually in childhood or early onset, suggests Dicer 1 syndrome that has been the most prevalent cause of multinodular disease. And this is just to show what one work we did, just showing the difference between cytology of a P10 and Dicer 1, and to see the ones that had papillary growth or not. They are both, but the Dicer 1 had more centripetal papillary growth. The P10, what's P10? So P10, we changed the name, not we changed this name was changed because encompasses multiple diseases. And like we have like the BRRS, the Rupa-Kappa syndrome, but the most common is Cowden. The BRRS is more common in children, but then we have P10 and Proteus kind of syndromes. And there are many criteria, but the major criteria is very important. But you see, within the major criteria, we have thyroid carcinoma. So that's another important thing. That's different from Dicer 1 because the major criteria is follicular nodular disease. So that's an important one. Just to summarize, we call P10 hamartoma because it's a molecular diagnostic term. And because we have multiple diseases within the P10 syndrome. So patients who have multiple, and I'm going to show you just fast few things. So the gene is in chromosome 10, and is usually autosomal dominant disorder, and 85% have a P10, but some other genes cause the same symptomatology. So sometimes even if you do the P10 immunostaining, that I think is very specific, it can be maintained because there are other genes mutations, just to remember. And this to me is, I had to present in the head and neck group once, the manifestations of P10, and I showed the criteria, and you see the most important is like this multiple tricholemomas. That's very easy to make a diagnosis. So many dermatopathologists in multiple tricholemomas, and you never think that the patient has hamartoma tumor syndrome, no P10. In the lemomas are like characteristic multiple. If you have more than 3, they say that's pathognomonic of P10 hamartoma tumor syndrome. And I love this picture here that we did. We published a few papers with a dermatopathologist from Mass General that we studied all the trichomomas because I wanted to make sure that we could really separate, and we did separate, like cases that are P10 loss, like the same one as I showed in the thyroid. And also, like if you see here, this is another paper that they show very well, like the P10 loss and the P10 maintained. So whenever you have the P10 loss, you could suggest the P10 hamartoma. The other lesions, there are skin lesions, papillomatous, papules, you have a lot of neuromas and the fibromas. And these gastrointestinal manifestations, even in the new book now, we have checked only on P10 manifestations of the GI tract because there are more and more lesions. And you can see this was an example of one patient that I had. I looked up the colonoscopy I suggested to do, and they found multiple lesions. And you can see here in the biopsy that I received had like a nice neuroma. So, and then this is if you find the diagnosis, who is a neuropathologist here, I mean, we don't see, but this was a case of my case that I had the thyroid, and then the patient had this tumor, so I did the P10, and you can see loss of P10 in this plastic cerebral gangliocytoma. And to summarize, most thyroid lesions are benign with excellent prognosis. However, there are multiple cancer risks in these patients. You have a breast carcinoma, thyroid carcinoma, and others. And the cancer screening and genetic counseling can be initiated as soon as the diagnosis. So, in thyroid, multiple adenomatous nodules, like we had in the background of lymphocytic thyroiditis, mostly in children and young adults, because causing disease is like young adults, and the BRRS is in children. So should alert the pathologist. So this case basically is to show you all these lesions in one patient, and I did the P10 and proved that then we did molecular, and there was a P10 mutation case. So there are multiple references on P10. And this is the beautiful, what I think is a beautiful case, that you see the normal thyroid with a maintained P10, and then here the adenomatous nodule lost. And in this case, the carcinoma, even the micropapillary carcinoma had also lost, because some lesions are not P10 related, any patient can have, but this patient had P10 loss in every single lesion. Thank you.
Vanya, thank you very much for a great talk. And as we know, in the 5th edition of a Blue Book, there is a extreme emphasis put on hereditary syndromes, and Vanya is the major brain behind the chapter on hereditary syndrome. So we are very lucky to have you here. Is there any comments on the talk? Do you want to ask or comment? We are pretty very well with time. We still have a lot of time. If not, there is time to exchange again microphone.
So now the last talk now is Martina, the new pathologist in the group that is specialized in head and neck, and I'm very proud to have more young people coming to this group. Thank you for coming.
Thank you very much, Annie. So let me introduce you case number 10. It was 52-year-old man with a history of forehead pain, tearing of the right eye, right nasal obstruction, occasionally with blood and nasal discharge, and impairment of smell. The first diagnosis that was performed was adenocystic carcinoma of the sinonasal area. The tumor was P16 negative, according to the department. And the treatment was endonasal resection of the tumor, which was followed by proton hemorrhagic therapy. We have only 90 days of follow-up. The patient underwent complete local remission, but unfortunately developed pulmonary metastasis, and now is alive with disease. Macroscopically, the sample was very fragmented, so it was not easy to check the periphery of the tumor, but we made what we can as good as we can. So the tumor consisted, especially the malignant component, consisted mostly of these two types, these two areas, these two architectural patterns. In the left, there is squamoid non-keratinizing area, and in the right, you can see the adenocarcinomatous component. The tumor growth, especially the squamous area growth, mainly in these solid structures, embedded by very thin fibrous septa, but occasionally with plasmoplastic reaction. You can see that there is pronounced mitotic activity, and even there were present the areas with sarcomatoid transformation, these pleomorphic cells with visible nuclei, visible nucleoli, which were in some instances very eosinophilic, high mitotic activity, even atypical mitosis. In some areas, these squamoid features were changed into these clear cell features, and also in here the mitotic activity is quite prominent. At the periphery of some fragments there was a suspicion for lymphovascular invasion, as you can see in the right. And also there was some neural perineural involvement, and also you can see in the center of the nerve. Yeah, here it is. So in the nerve there is entrapment of the benign respiratory gland in here. But what else we can see is it is hiding inside the tumor, and those are these small duct-like areas with colloid-like material inside, and they were present very well throughout the tumor. I will show you in the next slides, not in here, but in the following slides. I would like to show you also the superficial mucosa. You can see that the superficial epithelium was in some fragments composed of respiratory epithelium, but in some areas there was transformation. You can see the residuum of the cilia on the top, and in the right there are dysplasia, squamous cell dysplasia on the top of some fragments. And now, you can see that at the periphery of some tumors there are some budding structures of the REA, respiratory epithelial adenomatoid hamartoma, at the periphery, which was well circumscribed by the main tumor mass. And in some instances we saw these structures, small tubules with single line of cells, with colloid-like material inside, sometimes back-to-back patterns, sometimes interconnected, sometimes angulated and quite large, distended, with only mild nuclear atypia present, but nothing special. But when compared to the main tumor mass in the vicinity, it was quite striking that there is something inside the malignant component, and probably it was there before the malignancy arises. So in here, it is more pronounced, and especially it was at the periphery of the tumor fragments in close proximity to the superficial epithelium. Like in here, you can see the superficial epithelium with creation of such small tubules, again similarly, which we can see throughout this sample or this slide. So I perform many pictures of it because I like it. Okay, again. So now the immunohistochemistry, the tumor, the squamous component especially, was positive with P63, P40. It was completely P16 negative, and also there was no P16 expression in the dysplasia on the top. And you can see that those small chains which were seen in HE, they are completely negative. That's atypical for atypical sinonasal glands arising in ceremocinous hamartoma. Those atypical glands are typically positive by P63 only in a scattered fashion at the periphery of them, but usually they are like this, negative. This is SOX10 immunomarker, which highlights these areas I showed you before. I have many samples of it or many slides of it because again I like it, and you can see also that these structures are present already in the superficial portion of those samples in here. Okay, We perform also molecular genetic investigation, and we have found GGA2, PRKCB in out-of-frame gene mutation and in-frame EYA2, serine C3 it was double gene fusion. Along the DNA panel, we have found TP53 and other gene mutations as well. The molecular genetic investigation did not show any HPV relationship, and also the tumor showed no gene fusion, including CRTC1, MAMEL2, and including CRTC3, MAMEL2. So this double gene fusion is quite extraordinary. It was simply reported in one case. I mean, the GGA2 PRKCB was reported in the case of low-grade glioma, and EYA2 serine C3 was reported in a case of low-grade carcinoma of the ovary, but not in the sinonasal region. The diagnosis of this tumor is simple. It's adenosquamous carcinoma, but when they look at these small chains, it arises from ceremontinous hamartoma, and there was sarcomatic transformation. What do we know about sinonasal adenosquamous carcinoma? This tumor is composed of squamous and glandular features without any specific quantification of each component, I mean in the sinonasal region, because when compared to, or in contrast to lung adenosquamous carcinoma, lung adenosquamous carcinomas has established criteria. They are biphasic neoplasm with each component representing over 10% of the tumor volume. This tumor in the sinonasal region is usually associated to HPV infection. It is smoking-related disease, and also it was described to be related to wood dust industry. In the literature, there are less than 200 cases, so we do not have a proper view of all tumors which could be diagnosed as this. And historically, they were considered to be sinonasal equivalents of salivary gland mucoepidermoid carcinomas, but both tumors have different origin, molecular genetic background, and clinical course. As you can see in this table, the histology of both lesions could be quite similar, but the genetic background is different. In mucoepidermoid carcinoma, we usually like to see CRTC1 or 3 MAMEL2 gene fusion. It is present in over 80% of mucoepidermoid sinonasal carcinomas, but there are also fusion-negative mucoepidermoid carcinomas. Adenosquamous carcinomas have unspecific genetic background, and usually they are related to unfavorable prognosis. They often undergo metastatic spread even to distant locations, and the treatment should be more aggressive and followed by chemoradiotherapy, etc. Mucoepidermoid carcinoma usually is associated to very favorable prognosis and usually undergo rare metastatic spread. And the resection is usually enough, but when advanced, then the adjuvant therapy is also good to choose. And now what is the origin of adenosquamous carcinoma? Somebody believes that they arise from the ductal epithelium with subsequent surface involvement, or some believe that it originates in the surface epithelium and then invade the ductal system. There are three hypotheses, especially the second and the third are related to oral adenosquamous carcinoma, so they are not related to sinonasal, but I put them into this slide. The first one, that adenosquamous carcinomas may arise from minor salivary duct epithelium, it seems to suit to what we saw, that they arise from the residual ceremontinous cells of ceremontinous hamartomas or such precursor lesions like REAC. We know that ceremontinous hamartomas and respiratory epithelial adenomatoid hamartomas are a spectrum of one lesion with different phenotypes. So Ellis et al. Describes that the oral adenosquamous carcinomas may have a transitional relationship between mucosa and minor salivary duct epithelium, and Fonseca et al. Describes that oral adenosquamous carcinomas arises only from the surface squamous epithelium without any involvement of the minor salivary glands. So I take a look at the first study by Hartley et al., and they have supporting science for their hypothesis that the adenosquamous carcinomas from the sinonasal region arises from minor salivary duct epithelium. They think that the ductal carcinoma in situ, and they have proofs for it that these ductal carcinomas in situ may be present in early stages of the disease, that there are numerous multifocal carcinomatous changes within the ductal system with no surface involvement, and they also prove the presence of intracytoplasmic mucin within tumor cells that supports the glandular origin. So what about the squamous epithelium or squamous component of adenosquamous carcinoma? It seems that the neoplastic ductal cells are multipotent cells and have a potential to differentiation to different phenotypes, including ductal, squamous, mucin producing, and so on. We performed a study of this. We have collected 5 sinonasal adenosquamous carcinomas. It was quite hard to collect all those cases because they are so rare. And we performed nice imaging study of it, and if you want to, you can check the manuscript. It is in open access, and you can check all these slides in here. They are uploaded in full resolution. So this was case number 1, which was in a majority composed of the ceruminous hamartoma and Reach. Together they were quite striking and quite interesting because they did not create a typical glands of SH and Reach. And as you can see in here, for example, this ceruminous hamartoma is directly arising from the peripheral sheet of the Reach. And in here you can see that this is a Reach gland with cilia on the top, and the myellar epithelial layer like in here in the periphery, which will be completely P623 and P40 positive, it does not contain nice nuclei. It's these nuclei are a little bit atypical when compared to normal Reach glands. In here, it was in the area when there is a transition from those atypical sinonasal glands into the areas of adenosquamous carcinoma. This was another case where was a predominant component of these atypical sinonasal glands arising in Reach or ceruminous hamartoma. Like for example, in here, there is a back-to-back pattern of these ceruminous hamartomas glands transitioning into atypical sinonasal glands arising in ceruminous hamartoma. And again, this was the last case of our study. This case was, in addition, all 4 previous cases were HPV negative, but this case was HPV positive. There was also squamous dysplasia on the top, but at the periphery of the tumor, we saw again these glands of ceruminous hamartoma combining to Reach and combining to atypical sinonasal glands arising in ceruminous hamartoma Reach. So finally, adenosquamous carcinoma, it seems that it does not ultimately originate in a squamous dysplasia. There could be, probably, it's a controversial thinking, that there is another origin or precursor lesion, and that could be atypical glandular proliferation associated to ceruminous hamartoma / respiratory epithelial adenomatoid hamartoma. We also have a proof that there are some other malignancies that are associated to such atypical glandular proliferations, which were described first of all by Michal in 2024. And we described 2 tumors from the sinonasal region, low-grade tubulopapillary adenocarcinoma and adenoid cystic carcinomas to be associated with these atypical glands. Thank you very much for your attention.
Thank you so much. Who would like to ask questions? Yes, Dr. Please come here.
I would like to discuss, because the background of, thank you very much, the presentation was beautiful and very well documented. And I would like to say that, yeah, Michal is here, so I do not need to discuss. I just wanted to say that it was a great idea of Professor Michal to start with this atypical glands in Reach and sinonasal tract. And me and Martina, we were waiting like for the run 3 or 4 years. Thank you, Ivan. Thank you, other people who sent the adenoid cystic carcinomas of sinonasal tract. And we were waiting for Michal to give a signal to start to write papers about this phenomenon. And most of you, or some of you have been in Cancun and you listened to Professor Michal's talk about these atypical glands in rhea and sinonasal hematomas, and that's the major background of all these papers that were published later, and also background of this. This was consult case sent from France by Valeria Coster-Martino to me with diagnosis mucoepidermoid carcinoma. Please check again. It's a CRTC1-3 mammal 2 negative, so that's definitely something else. Maybe Michal wants to say something, because that's his idea.
Oh, great, and it's so nice to have you here.
I think I was because it's very long. I was not lazy. I wrote it 4 times the paper, and 3 times I threw it to the waste kit, so that I didn't know how to write it, and because I was afraid to write too many things and in one paper, so that we decided to divide the topics on several papers, out of which 3 were already published. The original one about epidemics, this paper, and about adenomyocystic carcinomas arising in these so far undescribed glands. And I would just like to tell you that the nasal region is one of the last place of human pathology that is full of undescribed entities. I just evaluate because we are getting together all sorts of biopsies from the whole world. When you realize in WHO classification there are only 3 types of polyps, averted, inverted, and oncocytic, but I can assure you that there are these 10 entities of polyps. We are introduced differently, that have different genetic background, and we are just now trying to collect them and collecting genetic data to write more papers. I hope I will be more successful to write it on first draw, not on fourth draw.
No, but and I listened to his lecture in Cancun, and there was like something that you always, like I always mentioned, you have to look at the little details of not just say, papilloma next, like, so.
I will just sum up the problems in salivary glands. We have 2 types of adenocarcinomas of nasal region. One intestinal type that arises from intestinal metaplasia, and non-intestinal. Just the non-intestinal just tell you that there may be a lot of tumors in non-intestinal type for which precursor has never been described. Nobody ever wrote where starts this non-intestinal type of adenocarcinoma of the nose. One of them is well known. It is that looks like arising from cerebrospinal hamartoma into tubulopapillary cerebrospinal carcinoma. It is one of them, but there are many others here. But I don't speak now about polyps. Polyps is different thing. Polyps is what there is called before.
Any comment? You have any comment, Martina?
No, I'm totally along with my comment.
One more.
The last thing I like to use Martina and Alena and the whole other academic team, because they usually write it better than I would write it.
I'm sure that's enough, but anyway, there is one more.
So as an old-time breast pathologist, I can tell you that David Page used to say there are 2 different types of breast pathologists, lumpers and splitters. And breast pathologists are famously splitters. I think we can now yield that designation to the ENT pathologist. I'm awed by the presentations this morning, so.
Thank you.
May I just say, I'm 85 and I learn every day something new. And I was preparing a lecture on lung tumors, and then I said there are 4 types of cells in the bronchial mucosa, and I said, let me see what does the artificial intelligence say, how many types of cells are there in bronchial epithelium. And to my surprise, I found that there are 17 cells. And so I would suggest that somebody does the same thing with the sinus mucosa, because there must be a lot of different cells.
That's going to be easy to be done here by the group. Yeah, they have everything. So that's great.
Slave.
Anyway, no more questions. So we are kind of finalizing the head and neck, and then now we have the GI group leading. So.
Thank you very much. After these great cases and wonderful discussions, we are moving to yet another probably very complicated and interesting area of GI and liver tumors. And the first case is actually mine. Does this work? No.
It does work. It works.
So, can you hear me well? So this patient is actually a 68-year-old man and was diagnosed with pancreatic ductal adenocarcinoma, PDAC. And I apologize, I'll refer to it as PDAC. So when I say PDAC, you'll know that it's pancreatic ductal, ordinary pancreas cancer in other words. And the patient received FOLFIRINOX, which is the standard treatment these days. And later on, he developed multiple recurrences and metastases, including in the pelvis, peritoneum, and these were all debugged. And much to the clinician's surprise, the patient was still alive in 2025, 7 years after the first diagnosis, and the patient came to us for targeted therapy advice. Now, 15 years ago, if we had a story like this where the PDAC patient survived 7 years, we would say there's no way. And we would bet that this is actually not PDAC, but some other cancer like neuroendocrine, colloid, and other variants. And most of the time, we would be right. Nowadays, with FOLFIRINOX and better surgery, we occasionally, still extremely rare, but occasionally see a long-term survivor of conventional PDAC. So far so good for this patient as a surprise, but it is agreeable too. And indeed, when we look at the morphology of the case, it does have many features of conventional PDAC. Scarce, ill-defined lesion, as you see here, infiltrating to the pancreas in a very patchy fashion, and it was composed of tubular units that had perineural invasion as well. And if you put these in words, saying infiltrating widely dispersed small tubular units embedded in desmoplastic stroma, that's the definition we use for PDAC in the pancreas. So far so good for, again, the diagnosis, and it did have very similar morphology also in the metastases that it produced. However, of course, we're at AMR, and I'm not going to show you a conventional PDAC, no? So there is a catch here, and here's the catch coming your way. Now, I looked at this case as an unknown, and I really thought immediately that there was something really fishy about this for a PDAC. And number one is, there's a striking monotony and lack of polymorphism in the tubules. This is not a feature of PDAC. PDAC is, I refer to this sometimes as the psychotic cancer cells. They really do whatever they want to do, and they do what they want to do. And you see, typically they will have multiple sizes and shapes of an invasive adenocarcinoma, whereas when you look at our case on the left, it really does have a striking monotony that is pretty much non-existent in PDAC. As importantly, PDAC cells are just unable to form lobular configuration. Don't get me wrong, I have a lobulated variant that is in my files, occasionally a little bit of lobulation, but this degree of lobular formations is pretty much non-existent in PDAC. And in some areas, we were also seeing that the cells were getting more compact and forming more nested trabecular configuration, which is also not a feature of PDAC. Here I'm highlighting again these really very lobulated, demarcated organoid pattern that speaks highly against pancreatic ductal adenocarcinoma. And when we looked at the cytology and architecture of these units, one thing that really catches your eyes is that yes, this is a high-grade malignancy, right? Very atypical, but there's a certain monotony, and especially the single prominent cherry red nucleoli are features that we associate with acinar cell carcinoma. And with this pattern, please look at this slide. This PDAC just doesn't do this. And moreover, we had enzymatic concretions that are illustrated here, which are the zymogen granule secretions that precipitate in the lumen, and they have this corpora amnesia-like configuration. Please stare at it. This texture is very good for acinar differentiation. Now, the cancer may be something else, but you can tell by looking at this that there is acinar differentiation in this area. We did immunohistochemistry, of course. Trypsin showed its usual blushy and frustrating positivity, but you see the negativity in the background. And in this slide, you're looking at a native pancreatic duct partially colonized by the acinar carcinoma cells. You see the nucleoli and monotony in those cells, whereas native epithelium is negative for the marker. Occasionally, trypsin diffuses and just gets into epithelial cells otherwise, but in this case, it read the books and it was fairly negative in the normal counterpart. So this is an acinar cell carcinoma. After all, what is a tubular infiltrative version of an acinar cell carcinoma, which is extremely uncommon, but we have seen a few cases of, and I'm hoping some of you will tell me after this presentation, yes, I have a case of this, because we're putting together a series on this, and it'll be great to increase our numbers and we can collaborate. And this is how, by the way, those of you who are not in the AMR, this is how AMR has done so many great projects and entities created by this kind of presentations and collaborations. I'm hoping some of you will contribute cases to this study. So let's go over the acinar differentiation and features of classical acinar cell carcinomas. Now, one of the main things acinar cells do are they have a distinctive chromophilia, and they have nucleoli because they're metabolically active cells. The cells that are more in the production phase, because of the rough endoplasmic reticulum in the base of the cells, has more basophilia. When you come to cases that have more storage of the enzymatic granules in the apex, then you get more acidophilia. But regardless, there's some degree of chromophilia that is quite characteristic of acinar differentiation that is displayed also in the cancers of these cells. Another important feature of acinar cell carcinomas and other non-ductal cancers in the pancreas is that they form sheet-like configuration instead of stroma-rich dispersion. They are more compact sheet-like growth patterns characteristically, which leads to this more demarcated round tumors in the pancreas rather than ill-defined that PDACs do. So on the left-hand side, I'm showing you in my files, I don't have any other case that is such a great acinus-forming acinar cell carcinoma. This actually we put in the previous WHO front page. This is acinar cell carcinoma that actually had massive neuroendocrine differentiation. Every single cell had both zymogen granules and neurosecretory granules. We did EM on this. I'm showing this to you to just, this is a side issue, nothing to do with our case, but please keep in mind acinar cell carcinomas often, very commonly have neuroendocrine differentiation, even at the ultrastructural level. Probably the most typical feature that helps us diagnose acinar cell carcinoma are these listed here: chromophilia, monotony, almost like melanomas, no? Prominent nucleoli, although they are high-grade cancers, so there are two examples illustrated here. And even those that form more acinar or rosette-like configuration typically don't have much stroma. They're, again, more sheet-like structures that are punctuated by these acinar formations. So this is typical for acinar cell carcinomas to be much more cellular without much stroma and forming these demarcated nodules. Immunohistochemically, the best marker we use is trypsin. And again, I'd like to emphasize the neuroendocrine markers are commonly expressed. Please do not be swayed by those. The other markers that are available and helpful are chymotrypsin, BCL10, and CEL, and they work quite well, but they're not as good as trypsin. And the problem with trypsin is, in many cases, look at this, this is a beautiful acinar cell carcinoma, again, all the characteristic features I described to you, but the staining is blushy, and this is, this is the color that sometimes you say, could this be a false positivity? And often trypsin, unfortunately, presents itself that way. Now, acinar cell carcinomas can divert from this textbook appearance and form more peculiar things like mucinous ductal differentiation. Where you draw the line to call it mixed ductal acinar is a different story, but here we see one that has exuberant mucin formation. In some cases, you even get goblet cells and tubules, etc. We often report these as focal ductal differentiation, but in the eyes of the beholder, occasionally even mucin-like globules can pop up in a conventional acinar cell carcinoma. Again, please notice the enzymatic concretions in the background that look almost like corporamylacia. This was a conventional acinar cell carcinoma otherwise. So going back to our case 11, it did really have very PDAC-like appearance, so it is a tubular infiltrative variant of acinar cell carcinoma. Again, very rare, but we've seen a few examples of. It was in some areas infiltrating like a PDAC. You see the islets entrapped in this scirrhous infiltrative process. And perineural invasion, of course, very common in PDACs that we associate with PDAC. But in contrast, very different from our PDACs is that there was the lobular configuration. Oh, by the way, this case also had areas that really looked like mesonephric adenocarcinoma, to my eye at least, with these small tubular units with acidophilic secretions in them. I think this is one way to recognize the other cases that we saw of this phenomenon also has this kind of mesonephric-like areas, something to keep in mind probably to make the accurate diagnosis. But most importantly, again, monotony, nucleoli, chromophilia, those are the features that tell us this is indeed an acinar cell carcinoma. This is not a feature of PDAC. Here's illustrated the cherry red nucleoli that is very striking. PDACs almost never do it in this manner. And we had the enzymatic concretions. Again, these enzymatic concretions are helpful, not just to tell you that there are some acinar products in that region. You can get these in, like in the stroma in chronic pancreatitis, and you will know that there's, injury to the acini. So it's a good marker for acinar differentiation in the neighborhood. And in this case, there was also some sammomatous calcifications. Why is that important? Because of this tubular configuration and monotony, you may think of glandular sammomatous neuroendocrine tumors in the differential, but it is not. This is an acinar cell carcinoma. They can have these precipitations in the secretions. Back to the history of our case, there were many things that were unfitting. CA19-9 was never elevated. Most PDACs, almost all PDACs, will have some degree of CA19-9 elevation sometime during the course. Most PDACs also present with jaundice and massive weight loss. This patient did not have that. Recurrences were always demarcated. Like I said, the psychotic acinar pancreatic ductal adenocarcinoma cells just unable to get together and form a compact mass. They just infiltrate in a very sneaky, insidious fashion, and they form these studying of peritoneal surfaces rather than forming a compact mass. And we'll discuss this a little bit in the next case presentation later on as well. And this patient also had molecularly some peculiarities. KRAS was negative. KRAS is extremely common in PDACs. It's debated whether it's 92% or 98%, but the vast majority of PDACs have KRAS mutation, and BRAF mutation is very uncommon. But this patient was KRAS negative and BRAF mutated. So if you have a case with this molecular profile, it's probably good to sit back and say, could this be an acinar carcinoma? Because there is a targeted therapy for BRAF mutated acinar carcinomas that seems to work well, and it's probably what happened in this patient as well. It is the combination of tremetinib and dabrafenib. Tremetinib is actually a MEK inhibitor. The main BRAF inhibitor is dabrafenib, but they are used together and they get good results in melanomas and other BRAF mutated tumors as well. And this patient is alive after several years. So this case is illustrating where acinar carcinomas don't read the books and present with something really peculiar and mimicking PDAC greatly. I try to illustrate the features that help us make the diagnosis accurately. And molecular, we don't do molecular routinely, although they ask, and it's getting more and more common. If you have a case, KRAS negative and BRAF positive, it's good to just wonder about acinar carcinoma in that case. Thank you very much. Yeah, so I'm the moderator, so I have to force you to ask me a question. Otherwise, the doors are locked, you're not leaving the room. At least select 2 people to ask some questions. Come on, this cannot be that straightforward. Anything, any comments?
So would it be worthwhile to do molecular genetics on cytologic material for this pancreatic duct-forming tumor?
Yeah, so I mean, look, this is very rare, so you don't want to change your practice for catching something like this, unfortunately. But we do actually cytology, we do NGS on cytology, or unfortunately, we can afford to do it. Not unfortunately. Fortunately, we can afford to do it, but unfortunately, not most people cannot. We have immediate evaluation for our pancreas, USFNAs. We have a very brisk USFNA practice in our institution, outstanding gastroenterologists. So we do the triage, and we actually do NGS on, and it's requested, and we are very, about someone we were talking yesterday, 80-90% of the cases we have the results. So you can get to KRAS and BRAF situation based on the NGS. But would I do it to catch this? Yes, it's totally impractical.
No. What I more mean is that it gives, for the subsequent workup when you have the resection and so on, you have a good idea whether you are dealing with something that is out of the ordinary, so you can get a little bit of smell of, no, I have to sort of stand back here, think twice.
Yeah, I mean, if you're thinking you're in this differential, it's a very peculiar tumor, doing the molecular could help you. Because KRAS is going to be negative in vast majority of Western carcinomas. So that's absolutely right. So you're wondering about this entity on cytology, I think molecular will be great help, for sure.
I was going to ask about, you showed KRAS right at the end, but P53 or SMAD4 and MTAP are very uncommon in Assener. Can be evaluated by the IHC, so that could be one way. Without spending a bunch of money or expecting everyone to do it.
That's
We're saying everyone should do molecular.
Very good. Yeah, no, you're absolutely right. Those are extremely uncommon in Asseners. But you know, with SMAD4, the problem is loss is very good in, seen in half of PDACs, but retaining. So you do your SMAD4, and if it's retained, it won't tell you anything. If it is lost, you know you're at PDAC level. P53 is a little bit tricky. It can be positive in any of these cancers in the pancreas. So P53, I don't think will be that discriminatory.
Less common than that.
Less common. But less common meaning I think 10-20%, if I'm not mistaken. 20% versus 60% is not something you can rely on the individual case, what I mean? I think SMAD4 will be helpful. If it is negative, that will be really strongly favoring PDAC.
I think MTAP as well.
MTAP we don't have that much experience with, to be honest with you, and I find the literature to be a little bit variegated in it. So we probably sit down and evaluate it more carefully. I have not done that. I don't have experience with MTAP much.
I found MTAP to be really garbage in the lung for mesothelioma, despite the studies that show perfect sensitivity and specificity in practice. Every single time I run it, it's like the opposite of what the mutational status is. It's ridiculous. So I don't know in the GI tract, but I have basically no faith in MTAP. I still order it, and I'm trying to get as much experience as I can with it, and every time I'm just did I not read this paper correctly? I just don't think the IHC in a lot of cases correlates very well with the underlying molecular genetics. Same thing with Merlin, which we use a little bit in mesothelioma. I just don't have a lot of faith in that. So.
Yeah, everyone at the back heard Dr. Schuster's comments. Yeah, it is actually, Dr. Schuster says MTAP and Merlin, he does not find to correlate that well with the molecular profile testing, and he finds it to be unreliable in general, right?
For mesothelioma. I don't have a lot of experience in the GI.
Yeah, I mean, that's what we are reading in the GI that's coming in too. That's why I wasn't, but then again, if you try it and do it right, maybe we'll find it to be.
I found it to be pretty helpful for PDAC, but
so we should probably.
Maybe our stains work differently.
Yeah, I mean that's a possibility too. Different antibodies, different labs.
I send all of mine to you.
Okay, that didn't explain the discrepancy.
Yeah, we don't have any of it.
Okay, so at least in some organs they're not that reliable, but needs to be tested. Okay, I think next speaker is Dr. Hagen, please.
morning, everyone. I'm Katie Hagen from Bioptická. So my case today is a 94-year-old woman who presented for right hemicolectomy for a cecal adenocarcinoma. The hemicolectomy showed a 4.6 centimeter lesion in the cecum as expected, and then representative sections were submitted for histology. So there was an invasive adenocarcinoma. We see, it extends through the muscularis propria into the subserosal tissue, consistent with a T3 adenocarcinoma, and that's not why I show the case. What kind of caught my eye and interest in this case was that many of the larger vessels in the subserosal tissue had this abnormal appearance with kind of this eosinophilic material within the vein wall. So at a little bit higher power, we see that appearance of the vein here. We can see the corresponding uninvolved artery, but the vein has kind of this dense eosinophilic material within the wall. It was kind of weakly positive on Congo red stain. We have some apple green fringens focally here on polarization. So overall concerning for amyloid. We did some additional studies, so fibulin-3 immunohistochemistry was strongly positive in these veins and these deposits. And then we sent all our suspected amyloid cases for mass spectrometry. And this came back with signature amyloid proteins, and it suggested that the type of amyloid in this case was EFEM. The diagnosis in this case was an incidental finding of EGF containing fibulin-like extracellular matrix protein 1, also known as EFEM, type amyloid involving the colon. And I present this because it's kind of a newer described type of amyloid that's primarily been described so far in the GI tract. So taking a step back, what do we know about GI amyloid in general? So the GI tract is kind of the third most common site that we see amyloid involvement. This is behind the heart and kidney. We recently did a case series of GI amyloid cases from our institution, and we found a total of 12 different types of amyloid involving the GI tract, with the most common type being AL type, followed by ATTR and AA type amyloid. And this EFEM type amyloid only involved a very small portion of our cases, less than 1% of cases, making it seem like it might be uncommon. In terms of other features of GI amyloidosis, greater than 75% of the patients, amyloidosis was an unexpected finding that was first made on these GI biopsies. So patients typically presented with non-specific GI symptoms such as diarrhea, GI bleeding, weight loss, abdominal pain, and over a third of these patients had normal endoscopies. So we can see that in general it can be very challenging to make a diagnosis of GI amyloid, both clinically and histologically. So we have to have kind of a high suspicion for amyloid in patients with kind of unexplained GI symptoms. Importantly, most of the patients that were diagnosed with AL and ATTR type amyloid were found to have systemic disease with cardiac involvement. So finding GI involvement was a sign of systemic disease. And it's important that these patients receive kind of prompt diagnosis because we do have good therapy for AL and ATTR type amyloid. So patients with AL type amyloid usually have an underlying plasma cell dyscrasia, so important that they receive therapy for that, and there are newer protein stabilizing agents which can be used for ATTR. So again, making this diagnosis on these GI biopsies in kind of a prompt fashion is important for prognosis and treatment in these patients. In terms of sites of involvement, so within the luminal GI tract, there was a high frequency of involvement in the stomach, colon, and small bowel. So 80 to 90% of these biopsies showed involvement. whereas the esophagus had kind of lower involvement, so 40% of cases showed involvement. So likely stomach, colon, or small bowel are all okay when we want to do biopsy sampling, when we have a suspicion for amyloidosis. Esophagus might be not optimal. In terms of the compartment of involvement, many of these cases showed submucosal vessel involvement, particularly the arterioles were involved. There were some kind of trends of patterns of distribution within the bowel wall, so AL type more commonly involved the lamina propria and the muscularis mucosa compared to ATTR, but this was not specific, so it could maybe suggest this type of amyloid, but again, you would have to do a more specific method of typing to definitively determine the amyloid type. So some examples of AL and ATTR type amyloid. Here we have kind of a duodenal biopsy with very subtle involvement by amyloid. So the duodenal mucosa essentially looked normal, and we only see kind of this subtle eosinophilia and the submucosal vessels of the duodenum, which is nicely positive here on our Congo red stain. So we can see that this would be pretty easy to overlook if we didn't have a high suspicion for this diagnosis. You could easily just call this normal duodenum, move on next. So again, important, if those clinicians have a suspicion for amyloid, to do that Congo red stain, and even without that history, unexplained GI symptoms, especially in an older individual, not a bad idea to do a Congo red stain. Again, these more common types of amyloid typically involve the arterioles, and so here we see kind of dense eosinophilic deposits within the arteriole. We see the thin-walled vein that is uninvolved in these cases, and again, the Congo red stain highlighting the deposits in these arterioles. And then here we see kind of more interstitial involvement, perhaps a case of AL type amyloid, where we see more diffuse deposition within the lamina propria, and also some within the muscularis mucosa here. And so again, we can see kind of involvement with any of those kind of compartments within the GI wall, but most commonly we do see deposition in those submucosal vessels. So getting back to this EFEMP type amyloid, EFEMP, also known as fibrillin 3, is an extracellular matrix protein. It's involved in cell-to-cell and cell matrix interactions. This was a newer type of amyloid that was first described in 2019, so again, relatively new. It's primarily been described in older individuals with a female predominance. And most cases have been described in the small bowel and colon, but there are continuously new sites that are being described, including stomach, bladder, lung, thyroid, so we're seeing more and more sites. In terms of the clinical significance, this first case that was described by Tasaki and colleagues in 2019, this was an autopsy case, and the patient died due to GI hemorrhage and colonic perforation, which was presumably related to these venous EFEMP amyloid deposits. Pretty much all other cases have been described kind of incidentally or at the time of autopsy, which maybe suggests, a lot of times this doesn't have clinical significance. In this autopsy series by Tasaki and colleagues, they actually also found a very high incidence of this type of amyloid in older individuals. And so in 30% of their autopsy cases in individuals older than 60, they found EFEMP type deposits, and then 60% of patients greater than 80, they found these EFEMP deposits, which suggests that we're probably missing this entity in clinical practice and not diagnosing it. If you remember to our GI amyloid case series, again,
again, the EFM represented less than 1% of cases. Unlike other types of systemic amyloidosis, this has not been shown to involve the heart, liver, or kidneys, so kind of our important major organs. So again, maybe a lot of times why this is kind of discovered incidentally. In terms of histologic features, we typically see these deposits primarily in the larger veins of the bowel wall. So again, this is a different distribution of deposition compared to most other common types of amyloid. We're seeing it in the veins as compared to the arterioles or arteries. We also can have some interstitial deposits as well. On histology, it can have that, classic eosinophilic appearance on H&E, but it can also have kind of a slightly bluish or grayish appearance, which, can maybe lead to misdiagnosis as well. And then on Congo red stain, it can be weak or even negative. So here we have maybe very weak, faint staining for Congo red. So this could also be kind of a diagnostic pitfall. So again, why are we probably missing it? Again, it can have that weak staining on Congo red, which can lead to false negative diagnoses. It can have kind of a subtle histologic appearance. Again, it's just kind of deep in those veins. And maybe we're not paying attention looking there. This typically is an incidental finding. Again, usually these specimens are performed for something else, like in this case, the patient had adenocarcinoma, and so this was just kind of an incidental finding. And then finally, this is kind of a newer diagnosis recently described, so there's probably still limited awareness by us pathologists. So some tips for making this diagnosis, we should have a high index of suspicion in elderly patients, and so when we do get those resection specimens from older individuals, if we look in the vein walls, we're probably gonna find it fairly commonly. Don't rely just on Congo red. This can be negative or weakly positive, which can be misleading. And so for diagnosis, what is really helpful is fibrillin 3 immunohistochemistry. Immunohistochemistry in general for amyloid typing can be a little tricky and non-specific, but the fibrillin 3 immunohistochemistry seems to be relatively specific and good. And then if you have it available to you, mass spectrometry is a really specific and good confirmatory test. So kind of to summarize, the preliminary data kind of suggests maybe this is just an incidental finding with limited clinical significance, but on the flip side, I think, this is probably an under-recognized entity, so we need to be aware of this, try and make this diagnosis so we can further study it and definitively understand the clinical significance. So with that, I thank you for your attention and happy to take questions.
So questions? I have a question. So you explained it well, but if you were to take the Tasaki results, 30% of the population over the 60 has it, and over 60 at the age of 80. It almost tells us that maybe it really could not have that much clinical significance, or even if it does, when we see it, can we really attribute all the findings to it or not? So that becomes a challenge, doesn't it?
Yeah, I think so far what we have for data, it suggests that it probably isn't very clinically significant. They did have that one patient that died of GI bleeding, which, it's hard to say 100% was that the cause or not. I think continued studies are important, but again, I think the data so far points us it's probably not clinically significant. I guess, if you don't have access to the immunohistochemistry or the mass spectrometry, you see these chunky deposits in veins, you can probably presumptively make this diagnosis and suggest, it probably doesn't have clinical significance.
Thank you. Other questions, comments?
Thank you, Catherine. Very nice presentation. Do you always need the confirmatory test if you get the fibrillin 3 positive?
Not necessarily. So I've had a few cases again in these older individuals. Probably they have other comorbidities that are probably more important to them. We've just done the IHC and said, if clinically there's an indication they want us to do the confirmatory mass spec, we can, but just kind of leaving it at the IHC, I think, is reasonable.
Thank you.
Yeah.
All right, thank you, that's great. I think next speaker is Dr. Hartley.
Hey, everybody, thanks. Great to be here. This patient, 34-year-old lady, she had a very large liver mass, 30 centimeters, obviously necrosis on imaging on the left lobe of the liver, and that's actually bigger than most left lobes of the liver. So when that's the case, anything that large in the abdomen, I usually think like sarcoma or something, carcinomas seem less likely in that context. But anyways, there's also a small lung nodule and a small adrenal nodule. On that note too, I've seen the adrenal sometimes can impinge on the liver and look like a liver mass. But anyways, this was a liver mass, and I just mentioned that. But so on the core biopsy, there wasn't really much liver parenchyma at all, and sort of monotonous, low power, high cellularity sort of sheets. There are some variation in the architecture. You can see sort of a glandular appearance or tubular appearance on top, just depending on what you think they're up to. And then, sort of more trabecular appearance here on the lower right. I wanted to try this thing out, that's pretty cool. And sort of a trabecular appearance here. And so in the context of a liver mass, that trabecular area at least, could look like a hepatocellular carcinoma, glandular area, you might think more metastatic adenocarcinoma, and then, the sheet area, diffuse area, more neuroendocrine tumor. But certainly all of this could be well within sort of the repertoire of a neuroendocrine tumor morphologically, and seeing them all together, I think sort of tilts it that way, just purely on a morphologic basis, and just to show a little higher power, just sort of very monotonous cells. There are a few mitoses around. All right, so kind of leading off of this neuroendocrine IHC, synaptophysin just kind of had this very sort of blush, patchy positivity. Chromogranin 9 SM1, SF1 are negative. Threw that in there just for the adrenal possibility, but not very impressive. So in this context, you could think of, I guess a high-grade neuroendocrine carcinoma. I suppose it'd have to be large cell, though. I guess there are these sort of intermediate small cells, and it gets a little tricky at times. As far as the hepatoid morphology, albumin-ish, pretty strongly diffusely positive, kind of moderate strong, but HepPAR1 and arginase were negative. You could consider maybe a poorly differentiated hepatocellular carcinoma. You could consider cholangiocarcinoma, although it sort of doesn't look much like that. As far as the glandular morphology, MOC31, not that that's specific to adenocarcinoma, almost any carcinoma will express MOC31, but in the context of a liver mass, it's useful, especially when it's strong diffuse positivity that favors in a primary liver tumor, cholangiocarcinoma over hepatocellular carcinoma. So this strong diffuse staining makes it less likely that it's a hepatocellular carcinoma, at least. Musicarmine is negative. As far as the glandular differentiation, and so this is the stain that sort of gives it away. Strong diffuse inhibin alpha positivity. I also did want to mention that CK7 and CK19 were also strongly and diffusely positive, which those sort of go strongly against hepatocellular carcinoma as well. So this was a cholangioblastic variant of intrahepatic cholangiocarcinoma. It's also known as NIP, BL, NAC1, rearranged cholangiocarcinoma. It's also been called solid tubulocystic cholangiocarcinoma. I think it's, I wonder what these were being called, in the past, but neuroendocrine tumor potentially, because they can have sort of variable weak to, sometimes moderate synaptophysin, but to date anyways, they're all Kroger and INSM1 negative. But you can still consider, it's well known that, high-grade neuroendocrine carcinomas can lose, the synaptophysin or all the neuroendocrine markers. Small cell carcinomas are pretty classic for that. But, there was that hepatoid morphology, and you have albumin-ish, so you might call it a day and say poorly differentiated hepatocellular carcinoma. I think that would be a fair diagnosis. You wouldn't be thinking about doing inhibin A really in that situation. As far as the glandular morphology, it's a challenge when they're hepatoid adenocarcinomas from the lung or from the pancreas that metastasize to the liver. That can be challenging, but mesocarmine and sort of the clinical history can help out there. And then, adrenocortical carcinoma with an inhibin positivity, but SF1 is negative, and obviously this being a liver mass, it's less likely. But I did mention how sometimes adrenal masses can sort of push up into the liver and seem like primary liver masses. The history of this entity, 2005, there's a case report of hepatic adenocarcinoma expressing inhibin, and that's actually, I think that's an accurate diagnosis, sort of implying it's a primary adenocarcinoma. In 2017, we get the term cholangioblastic variant of intrahepatic cholangiocarcinoma. I suppose, not in my example, and actually not in many others, there's sort of a blastic morphology, like higher NC ratios, but as you saw, these tumors didn't really have particularly high NC ratios. But anyways, and then the translocation was discovered in 2021, Arkadi et al., and here's the nice fish image showing the break apart curve, the greens and the reds, and not many yellows around. So, but that's not required for the diagnosis, thankfully. So that albumin-ish and inhibin staining are strong diffuse in every case it's been described. So I just want to show a bit more morphology because the case I had didn't quite have it all. But there is a lot of heterogeneity in this entity, which is interesting. We've seen that a lot actually, in the translocation tumors presented today. There just seems to be a lot of this morphologic heterogeneity, especially architecture-wise. Cytologically, they often tend to be pretty monotonous. But anyways, there's this really cystic area over here. Sorry, I guess it's not working, but you can probably see what I'm talking about there. There's also this sort of papillary, pseudopapillary stuff here. I don't know, that's not here we go. Yeah, this sort of pseudopapillary kind of area. So, you could, with that weak synaptophysin, I guess you could consider a solid pseudopapillary tumor there. But anyways, and then that's sort of more monotonous neuroendocrine looking area as well. So the clinical features of this large hepatic masses in young women without underlying liver disease. So that's kind of another interesting feature that almost none of these patients had significant chronic liver disease sort of predisposing to this, and so mean size 14 centimeters, mean age 42 years old, and 90% did not have any underlying liver disease. So compared to at least conventional cholangiocarcinoma, there's generally more favorable prognosis, particularly when they can do complete resection. But having a good prognosis compared to conventional cholangiocarcinoma isn't the best. But anyways, and there's only, I think there's like 50 cases that have been tracked in sort of a meaningful way in the literature. So there is high grade progression that can happen with RB or P10 loss. That's something you can see. Well, it's a treatment escape pathway in lung adenocarcinoma is loss of RB as well. But interestingly, in the differential diagnosis, when we were talking about high-grade neuroendocrine carcinomas that lack expression of synaptophysin chromogram INSM1. The RB loss is frequently seen in almost every small cell carcinoma, for example, and a significant number of large cell neuroendocrine carcinomas. So that could be another potential pitfall if you were trying to use RB-P53 to favor a high-grade neuroendocrine carcinoma that's had aberrant loss of the neuroendocrine markers. So yeah, this case was a very classic example. This entity, a young woman with a 30-centimeter mass, and so just the better prognosis is always nice. And that sort of varied morphology, solid trabecular, pseudopapillary, tubulocystic, and strong inhibin alpha and albumination. And every example so far has followed the rules on that, but maybe there'll be one that'll break it eventually. But and then sort of that weak synaptophysin, but lack of the other ones. And the fusion that today doesn't mean much. That pathologically, it doesn't seem to have any association with as a disease driver, although it obviously must. But anyways, that hasn't been really explored in any meaningful way, as it's kind of an orphan disease of sorts. But I suppose some pharmaceutical company can make some money off of finding it, but some treatment for it. So the reference is just arranged by date here. But yeah, thanks for your attention. I'll take any questions.
Questions, comments?
Thank you so much for a nice presentation. Just want to learn from your presentation, from your case, why called cholangioblastic? Because to me, plastic means something like developmental tumor, and why these cases are called cholangioblastic, just for my learning experience.
Yeah, I think it was some of the early examples had areas sort of with higher NC ratio. I don't think it's the best term either necessarily, but I think it was the earlier, the first, I forget the other name on that, but that paper, they proposed that name, so I think even hepatic adenocarcinoma with inhibin expression is maybe a more useful, useful name for it.
And mostly because of plastic, besides mimicking the blastema, the formation of the filaments, but also nowadays means more dicer one mutation, and this one has a translocation.
Mm-hmm.
So that's why I don't like the term for a tumor that has a translocation and that not belongs to the other groups of diseases.
Yeah, I guess I should have mentioned the preferred name, I guess, in the field now is the NIBPL-NAC1 translocation cholangiocarcinoma. That is the preferred name. So.
Oh, okay, good.
Yeah, sorry.
No, good, because just to clarify here.
Yeah, thanks.
But Chris, that's the preferred name in academic circles, because most people are not going to be able to do it as translocation, so we're going to have to call it cholangioblastic or some other morphology-based name. I agree, cholangioblastic may not be the best term, but other terms were taken, so. And also there's a little bit of resemblance to hepatoblastomas that have a little bit more neuroendocrine look too, so that was another factor there. I have one question though. I think you gave such a beautiful description of the entity with neuroendocrine look and less. Do you think the tubulocystic ones, just because inhibin, that they really belong, I mean, isn't it pushing it a little bit too much to put the two together? In our impression, tubulocystic ones are really a very different beast. They have the background is usually have hamartomatous lesions and other things. What's your experience with the tubulocystic ones? Do they really belong together?
Well, first of all, I've only seen 2 of these so far, but and they were both like the morphology.
Yeah.
But I mean, to me, if you have that strong inhibin and then the translocation, I guess it'd be hard for me to separate them, not split them. But yeah, I mean, it's whenever there's that striking of morphology difference, it always raises the
Yeah, it is.
possibility. Yeah.
They really, I mean, morphology is so vastly different between each other. So
But yeah, that another name for it is the tubulocystic. But that, you know, again, that then you don't think of the other ones that are more solid like that. So yeah, that's none of the names really are great for this one. So.
But that one is a peculiar marriage, right? Putting the two together.
Yeah.
So any other questions or comments? If not, thank you so much, and we move on to Dr. Fedeli, sir.
Good morning. The case is 79 years old, a male that presented with nausea, vomiting in the area. CT scan revealed an abdominal mass, but the laboratory test no increase in CA1 to 5 and CI level. The macroscopic finding I can show you because derived from another institution was 6 centimeter of jejunum and 42 centimeter of ileum, and there was present many lesions in the jejunum and 4 lesions in the polypoid lesion in the ileum. And here there is the morphology of this tumor. There is the ileum that was infiltrated by this massive tumor, and the morphology of this tumor is constituted by this cell in diffuse aspect anyway, and the cells are eosinophilic. The nuclei are round to oval with big nucleoli, and but the cytoplasm was indistinct and eosinophilic. Many areas of necrosis were present, and many mitosis are present, like here in the upstairs and in the low part of the slide. In some area there are some cells with polymorphic, and many of the cells are binucleated, like here, and mitosis, very atypical mitosis. And so, in summary, we are dealing with a tumor with solid pattern extending in the overlying mucosa. The neoplastic cells are large and pleomorphic, and the nuclei are round to oval with spindle and vesicular chromatin. The cytoplasm was abundant and eosinophilic. This is a really important thing. And many cells are binucleated and multinucleated. Necrosis are present, and high mitotic activity was very, very high. And in the middle of the cell, there was a mixed inflammatory infiltrate. And so, differential diagnosis. The first hypothesis was metastatic melanoma, because metastatic melanoma is more frequent tumor in the ileum and the jejunum. And the other one, large cell non-Hodgkin lymphoma, like diffuse large B-cell lymphoma and anaplastic large cell lymphoma, or metastatic undifferentiated large cell carcinoma, or undifferentiated pleomorphic sarcoma. We performed a lot of immunostain, but melanoma was excluded, completely was excluded. The S100 was negative and MAC1 was negative. Metastatic undifferentiated large cell carcinoma, cytokeratin was completely negative in all part of the tumor. There was positive only in the gland, but not in the tumor. And large cell lymphoma was LCA positive. Anyway, we can see the pimentin was positive, LCA was positive, not in all cell but was positive, but CD20 was completely negative, just some cells that are present inside of the tumor, but the tumor was negative. CD30 was positive, some cell was just a little bit positive, but the whole part of the tumor was negative, but was completely positive CD68 PGN1 and CD68 KP1. and the tumor was CD163 positive. But S100 was negative, there is an interdigitating cell, and CD1 was negative. And so in summary, the tumor is CD68, the two type of 68, CD163, but was negative with all other type of marker that we can use, and is the list here. Actin has been completely all negative. And our diagnosis was multifocal histiocytic sarcoma of the gastrointestinal tract. Is a very rare tumor, very rare tumor. In the literature, every 1,000 lymphoma cases, there is 4 histiocytic sarcoma. It's very rare tumor. The incidence is 0.17 million of individuals. And the tumor for in adult, very rare cases in pediatric case, occur more in male than in female, and the tumor is more frequently in, it's very rare, but impossible to find in gastrointestinal tract, spleen, liver, soft tissue where is present histiocyte. Rare in the skin, lymph node, and brain. And there's a tumor very frequently in dog. I don't know why, but it's very frequently in dog. It's different, the morphology in lymph node, because there is sinusoidal pattern. Instead, in gastrointestinal tract, like in our cases, is solid pattern. It's composed by large cell with oval to round vesicular nuclei, and the appearance is reproducible because is in all type of the tumor is the same, in the literature is the same, is completely the same. And the tumor is positive for CD68, CD163 and LCA. It's negativity for T and B and dendritic cell markers like S100. Very few cases are described. This is a group from Fletcher. It's about 20 years ago, but there is no other series of this type of tumor. And in this series, derived from 10 institutions. Don't derive exactly from the place where Fletcher worked, but from 10 institutions, 2 from Italy, anyway. And in this group, in extranodal histiocytic sarcoma, only 1 case was a terminal ileum. And so you have to understand that it is possible to find here. And the immunohistochemical is similar. Our immunohistochemical is positive for LCA, for PGM1 and for KP1, and negative for S100 and CD1. No specific etiologic agent was discovered. In the literature, about 25% of cases was transdifferentiation from B-cell lymphoma, derived from a lymphoma that was present before in the gastrointestinal tract and after developed a histiocytic sarcoma. The clinical presentation is diversely related to involve organ normally, but the limited literature is available on the management of these entities, so rare that it is possible to have a very good guide. Was found a monoclonal EGH gene arrangement, and some cases of histiocytic sarcoma show BRAF mutation, and so this is very good possibility to have a vermurafenib and trametinib for a very observable response to kinase inhibitors. And recently, a high rate of PD-L1 expression in histiocytic disorder suggests that immunocheckpoint inhibitors such as nivolumab could serve as a potential therapeutic option. There is described some alteration in KRAS or MEK2-K1, but it was relatively prevalent, but very few study was done. why I presented this case? Because it's very rare. And sometimes when you are dealing with a tumor in ileum, you don't understand, you don't think that it's possible histiocytic sarcoma. Because sometimes don't do the CD66, 68, another one. Immunohistochemical is the marker to confirm this histiocytic differentiation. Thank you.
Questions, comments? It's a great case. Because we had a skin example recently, and I had a hard time convincing our colleagues that it was histiocytic sarcoma showing exactly the same panel. So it's a beautiful example that needs to be kept in mind.
Because every case that are described. Yeah. Because it's so rare that if you don't find the case, you describe.
Questions, comments? Histiocytic sarcoma? Okay. So if there are no specific question, I think we hope to have everyone back here at 1:30. In terms of where we go from here for lunch.